Sir.
Okay, so I'm Dr. Amola Parekh, President BSA, and I invite you all on behalf of BSA for our first event of our tenure. We proudly want to share with you this first event of our tenure on malignant hyperthermia. I would like to invite the SAMS, Society of Association of Maharashtra State President, Dr. Balaji Asgaonkar, and the Secretary, Dr. Rajesh Tagadpale, and all the dignitaries here, the speakers and the chairpersons and the panelists, Madam Kelkar, Madam Dr. Vikas. Welcome you all for our meet on malignant hyperthermia. This is a very rare but a dreaded complication, and that is why we thought of arranging this webinar. I now invite my scientific secretary, Dr. Tej, who is a private practicing anesthetic in Virar Vasai area. I invite Dr. Tej to please continue the proceedings.
Thank you, madam. Namaskar.
Namaste.
My name is Dr. Tejveer Singh Chauhan. I'm the Scientific Secretary, ISA Borivali. I welcome you all. Very good evening. Well, I'd been muted. Yeah. We must have heard of malignant hyperthermia in our PG days or afterwards. We've read about it. Fortunately, most of us have never seen it. I would say fortunate because it has very high mortality. Fortunately, it is very uncommon. But in the last year, we heard about 2 cases within a span of a few weeks. And then it made us realize that every life is precious. And we must discuss this, even though it is a rare complication. We should discuss it and come out with some guidelines or something which can reduce the mortality, something which can improve the outcome. So for this, we are gathered here. I would like to introduce my chairpersons today. Dr. Rajiv Garud sir, he is the Vice President of ISA Borivali. He is a very senior anesthetist. Did his MD from JJ Hospital, Grand Medical College. He worked in Nanavati Hospital initially and then switched to freelance private practice. He's had experience of more than 30 years. And the second chairperson I would like to invite is Dr. Rajesh Rao sir. He is the Honorary Secretary of ISA Borivali. Sir has done his MD from Sion Hospital and he is very experienced, more than 30 years, freelance practitioner in northern suburbs of Mumbai. He also has a hospital. And over to you, Garud sir, to take the matters further. Thank you. Garud sir, please unmute yourself.
I'm Dr. Rajiv Garud. I'm Vice President of this Borivali Society of Anesthesia, recently formed a panel. And we are beginning our first webinar on malignant hyperthermia, which is a very hot topic and very vital to know about for everyone. Now I request our Secretary, Dr. Rajesh Rao, to introduce the speakers and proceed.
Or
first speaker, I will introduce. Our first speaker is Dr. Deepti Thakur. She has done MBBS from Government Medical College, Solapur. And she's currently doing residency for diploma in anesthesiology at Zen Multispeciality Hospital, Chembur. I request Dr. Deepti Thakur to proceed with her presentation.
Ganesh, please stop screen sharing.
Hello.
Yes, ma'am. You are audible.
Hello. Good evening, all of you. I am Dr. Deepti Thakur, second year DA resident at Zen Multi-Speciality Hospital, Chembur. Here, I'm going to present the case report of a 21-year-old male patient, 61 kg weight and 176 centimeter height, admitted to the Zen Hospital for bilateral sagittal split osteotomy for mandibular setback. The pre-operative assessment revealed no history of comorbidities, not on any medication, had no history of previous anesthetic exposures, no drug allergies, with Mallampati of 2 and prognathism, but adequate neck mobility, anticipated as a difficult intubation and ventilation. General anesthesia started with pre-oxygenation of 100% oxygen, pre-medication of intravenous glycopyrrolate 0.2 mg, ondansetron 8 mg, fentanyl 120 mg given, induction with intravenous 2% lignocaine of 60 mg, propofol 150 mg given. Rapid bolus of succinylcholine 100 mg intravenously given and fasciculation noted. Then nasal intubation with 7 mm North Pole cuff endotracheal tube with direct laryngoscopy done. Throat pack also inserted. Ventilator support with tidal volume of 400 to 450 ml, respiratory rate of 16 to 18 per minute with PEEP of 5 on volume control mode with FiO2 50% with air and oxygen maintained. 40 mg of atracurium were administered for relaxation of muscle. To maintain the anesthesia, sevoflurane at 2 to 2.5% with MAC of 0.8 to 1.2. Maintenance dose of atracurium administered. Patient underwent surgery and position for the surgery was a supine position. Intraoperatively, heart rate was in between 80 to 104 per minute. Systolic blood pressure of 100 to 120, 148 millimeter of mercury. Diastolic blood pressure of 60 to 86 millimeter of mercury. And maintaining of saturation 98 to 99%. EtCO2 was in between 34 to 36. 1000 ml of intravenous fluid ringer lactate and 500 ml of normal saline infused. Surgery went for 4 hours to 35 minutes. Total urine output was 120 ml and total blood loss was 80 ml. The patient was extubated with standard extubation criteria with intravenous reversal of neostigmine 2.5 mg with glycopyrrolate 0.5 mg given. The patient came out of anesthesia well with power tone reflex intact. So patient shifted to recovery. In recovery room, heart rate was 122 per minute. Systolic and diastolic blood pressure was 156 to 82 millimeter of mercury. Patient was maintaining the saturation of 98% on room air, but patient was complaining of severe body ache, myalgia, and backache. So patient felt warm. So we measured the temperature and it was shown 104 degree Fahrenheit. So patient was managed in recovery room with cold sponging, cold saline of ringer lactate, and injection paracetamol 1 gram. Temperature reduced to 100 degree Fahrenheit within a half an hour, and patient was vitally stable. So patient shifted to intensive care unit for further management in view of possibility of post-operative febrile illness under evaluation or malignant hyperthermia. Post-operatively, patient underwent evaluation at intensive care unit. So patient was complaining of muscle rigidity in both the upper limbs and lower limbs with the neck and back, especially paraspinal and chest region with tenderness. Facial and lip swelling noted. Patient was vitally stable and maintaining the saturation of 98%. Temperature measured and it was shown 100 degree Fahrenheit with respiratory rate of 16 per minute. On Foley's catheterization, cola colored urine notice and urine output was not adequate. So central line right IJV secured with CVP of 5. So 500 ml normal saline infused, adequate hydration given, and patient managed with injection paracetamol 1 gram TDS for 5 days, injection Palsigo 120 milligram for 3 days, injection antibiotics, injection dexamethasone, injection furosemide, diuretics 20 mg for once a day, intravenously. Tablet bromocriptine 2.5 mg TDS given and tablet clonazepam 0.25 milligram TDS given. Ice fomentation also applied for the hyperthermia. On post-operative day 1, ABG analysis done and it was normal. So patient further evaluated clinically and with investigations. So on day 1, on post-operative day 1, the temperature was showing 100 Fahrenheit with leukocytosis of 17,140 WBCs. Serum creatinine was 2.23. Urine output was not adequate, around 20 to 25 ml per hour. Hyperkalemia of with potassium 5.7. Serum calcium and magnesium were normal. CPK total was high, 38,324, with creatinine kinase also high, 329.9. Serum myoglobin and urine myoglobin shown to high, which is serum myoglobin is more than 3,000 and serum urine myoglobin is 541. So on post-operative day 1, the HD type of dialysis done as intensivist suggested. On post-operative day 2, the patient was having the same complaint of muscle spasticity, upper limb, with upper limb more than lower limb, with fever of 101 degree Fahrenheit temperature, vitally stable, respiratory rate of 14 to 16 per minute, with normal systemic examination, but oliguria was there with cola colored urine. ABG analysis done on post-operative day 2, which came out to be normal. The patient with hyperthermia, muscle spasticity, high serum creatinine, oliguria, increasing trend of CPK total and creatine kinase, high myoglobinemia, myoglobinuria, cola colored urine, and UHG abdomen with pelvis, suggestive of acute kidney injury. So intensivists made the provisional diagnosis of as possibility of malignant hyperthermia with acute kidney injury with rhabdomyolysis. So intensivists have decided to give intravenous injection of dantrolene at 1 milligram per kg dose. So 60 milligram of dantrolene given on a post-operative day 1. After 3 hours of dantrolene therapy, patient had nausea, dizziness, and 2 to 3 episodes of vomiting, which treated with the antiemetics. On post-operative day 3, patient was having the same complaints of muscle spasticity, with upper limbs more, with oliguria, cola colored urine, and with high serum creatinine and high CPK total values. But patient was vitally stable, systemically non-significant. So patient continued with HD type of dialysis and hydration therapy and symptomatic treatment. The treatment given on day 3, intravenous paracetamol 1 gram TDS, injection intravenous antibiotics, injection dexamethasone 8 milligram twice a day, injection furosemide 20 milligram once a day, and tablet bromocriptine 2.5 mg for TDS and tablet clonazepam 0.25 milligram TDS. Patient started improving in 1 week with upper limb rigidity present. Patient was afebrile, adequate urine output, decreasing trend of the CPK total. So shifted to ward for further management with the same line of treatment. Total 5 HD type of dialysis patient underwent during the post-operative days. So in a day, in a week 1, on a day 7, post-operative day 7, patient was afebrile, serum creatinine 7.4, urine output was adequate 35 to 40 ml per hour, potassium was normal 4.4, and CPK total was 1,155, which is in decreasing order. The patient significantly improved clinically within the 3 weeks with serum creatinine going to 1.4 on within the 3 weeks, and creatinine kinase and CPK total and myoglobin levels came to normal within a 3 weeks. The patient improved clinically within a 3 weeks. These are the post-operative investigations done by the intensivist of this patient, that showing the temperature on day one and day two was high, 100°F, and on day two, 101°F. After day 3, it came to normal. On day 2, they have given the dantrolene injection therapy and HD type of dialysis on post-operative day 1, 3, 7, and 10 and 12 done by the intensivist. Then serum creatinine came out to be normal within a 3 weeks, which came out to be 1.4. Potassium of day 1 was a patient showing hyperkalemia on day 1 with 5.7 potassium, which came out to be normal in a 3 weeks. CPK total in a decreasing orders. On 4th of August, it was 457, and in a 3 weeks, it came out to be normal. This is the case of delayed onset possibility of malignant hyperthermia. Thank you. Thank you, ISA Borivali. Thank you, Dr. Vikas Nair, sir. Thank you, Dr. Ratnakar Gosavi, sir. Thank you, Dr. Kale, sir. And thank you, Zen Hospital, for giving me this opportunity to present this case. Thank you so much.
Thank you, Dr. Now, I just request all the delegates to note down the questions and queries in the chat box, which will be taken subsequently in the panel discussion. And please mute yourselves. Now, I call upon Dr. Avadhoot Kulkarni, the next speaker.
Dr. Rajesh, can I add a couple of things?
Yes, yes.
So, this case was primarily done by Dr. Ratnakar Gosavi. This case, as told by Dr. Deepti, went on for 4.5 hours. So it is highly creditable on the point of Dr. Ratnakar that is suspected malignant hyperthermia, because I was outside the hospital somewhere else. When the patient came out into the recovery room, seeing the temperature, he called me for help, but he never let the primary diagnosis of malignant hyperthermia from his mind, from his differential diagnosis. In fact, I thought this must be a concomitant viral infection or malaria which was there, but he said no. Hello?
Yeah,
Hello?
Please note these questions now. Yes, Dr. Vikas, please continue.
Yeah. So as soon as I reached the recovery room, 2 or 3 things which I noticed, which was very significant. Number one was the pulse rate was from 120 to 140. Temperature, when I first saw, was around 104. And a very unusual sort of severe myalgia, especially between the shoulder blades and the front of the chest. He said, do whatever. There was no pain here where the surgery was, but he was complaining of severe myalgia in between his shoulder blade, in between his scapular blade. So these were 3 things which made us think of malignant hyperthermia. And then we shifted the patient to the ICU, and from there on, all these things happened. Dr. Deepti is a student there, and she was following up the patient, and she has done a wonderful job of following up the patient and keeping all the notes. And we are very glad to say that the patient has recovered well. His last creatinine now was 1.4. We have asked him to come here to get a genetic testing done. Unfortunately, he's lost a lot of time during this hospitalization, and he's an engineering student at Kerala. He says once he gets some extended leave, he will come here for the genetic testing, which is to be done for the final diagnosis. Thank you.
Thank you, Dr. Vikas, for the synopsis. Thank you very much. Excellently managed case. You will be asked the question, so where did you get dantrolene later on? We'll talk on that about later on. So now I will invite Dr. Avadhoot Kulkarni Dr. Avdut is a freelance consultant anesthesiologist affiliated to Thermi Hospital, Surya Hospital, Pune Hospital, and his area of interest is ortho anesthesia, anesthesia for laparoscopic surgery, and regional anesthesia. I please request everybody to mute themselves. Lot of disturbance, please. Yeah, Dr. Avdut.
Varsha madam, can you do the needful, please? Varsha madam or Mr. Ganesh? Can you please mute everybody?
पेशंट ला
Too much of disturbance.
मला ब्लॉक द्यायचा आहे किती असं लवकर जास्तीत जास्त
Ganesh, please.
Yes, sir. Yes, sir. Yes.
Ganesh, please be around. Don't.
Yeah, Avdut, please start your talk. Dr. Avdut to share his screen, please.
अवधूत सर अनम्यूट कर लें.
Dr. Avdut, please start your presentation.
Yeah, am I audible?
Yeah,
Yes, sir.
very
Yes,
much.
yes.
Yeah. So, see, this case has happened in the early years of my practice, maybe about 20-25 years back. This was a child which we did in a pediatric nursing home with NICU. The pediatrician had a patient for rectal polyposis. This was a 3-year-old child from a low socioeconomic strata. Female child must be around 12 kg for a rectal polypectomy. Preoperatively, everything was unremarkable. The investigations were normal. So typically for these patients, we end up giving a short anesthesia where we induce the patient, put the patient in lithotomy, and surgeon has to remove the polyp. Just when he has to remove the polyp, we give 1 dose of dexamethasone. There is a relaxation of anal sphincter. He goes in, takes a stitch around the polyp and removes the polyp. So it's a very short procedure, about say 15-20 minutes. So this is probably, the details are a little sketchy, but roughly we gave atropine, pentazocine, midazolam, thiopentone. Routine monitoring, we had started oxygen, nitrous oxide, halothane, spontaneous ventilation, lithotomy was given. A shot of suxamethonium was given. We put oral airway, put the patient on IRCPs, and we ventilated the patient. The procedure surgical time was just about 15-20 minutes. Surgery was uneventful. Patient was shifted to the ward. So far, so good. It's a standard short case in the middle of a heavy day. After 1 hour, the story started. So I received a phone call that child had fever. So many times post-operatively, they have fever. So we thought it could be just about 100-101 degree Fahrenheit. We gave injection Acnil. Acnil, as you know, is paracetamol in 2 ml ampoules. So we gave Acnil. There was not much difference. They started sponging the child. After about 3 or 4 hours, the fever became 104 degrees. They again called the fever is increasing. Child is irritable. Then we asked IV paracetamol. Tepid sponging started. Then the pediatrician left his OPD, and me and pediatrician both reached there. First, we thought it could be dehydration. Child must be starving excessively, so started fluids. We pediatrician also thought 104 is a little unusual for a dehydrated child, so he thought of sepsis. I said, why sepsis? The child was totally fine before the surgery. He said, nevertheless, we have to rule out a few things. But I was thinking of malignant hyperthermia could be a possibility since we had used all the agents which are implicated like succinylcholine and halothane. So pediatrician was not very sure. Child now after about an hour or two became unresponsive. The irritable child, tachypnic, became unresponsive. Saturation became 96%. 9 BP was still okay. And there was no child had not passed urine. So we passed a catheter. Pediatrician still was suspecting a septic focus. The antibiotics were stepped up. Also put a ice tube for cold saline lavage. Tepid sponging continued. Temperature kept on rising. X-ray chest was done. Child was catheterized. There was hardly any urine. Whatever were a few drops were there were sent for routine and microscopic. Fluid challenge was given. He also did asked me to do a CSF puncture to rule out any other problems, which also we did just to complete the list. So I asked one more anesthetist to come. We sent investigations meanwhile for CBC, electrolytes, and CPKMB. That time, locally, obviously, it was not available. We tried to get the number of royal chemists at Marine Lines, which was probably the biggest chemist of Mumbai that time, where things used to be available, imported drugs, etc. He also didn't have dantrolene at that time. So we continued with conventional line of management. Child was unresponsive. We kept on repeating paracetamol, kept on doing tepid sponging, gastric lavage. We gave cold water enema. We started calling up anesthetists in South Bombay who were very senior. One of them suggested you give Largactil, all the systems will slow down and probably the fever will also come down. Largactil, I don't know if juniors may not be aware, but my seniors must be there who must have known Largactil. That is chlorpromazine, which generally lowers down the body response to a lot of things like it causes a decrease in the respiration, blood pressure, everything. So they thought that even fever would slow down, but nothing like that happened. We also did a CT scan brain because child was totally unconscious by now. CSF analysis report meanwhile came, which was unremarkable. So nothing was going in our favor all the while. So we did blood gases. Now, first time we got something that the patient blood gases were showing hypercapnia, metabolic acidosis. CPK report also came, which was 250, and potassium was 6 milliequivalents. So potassium was high, CPK had increased. For such a short procedure, you should not have an increase in CPK. Then definitely that means that something has gone wrong. So probably we were thinking now malignant hyperpyrexia as a first line diagnosis, but nothing more could be done for the child. Since there was hypercapnia, metabolic acidosis, even though correction was given, we decided to put the child on ventilatory support. The child was intubated, put on ventilatory support, but the child continued to deteriorate. Fever went to 108. It was out of the thermometer. We were checking the rectal thermometer all the while. There was tachycardia, and then the pulse started becoming irregular. The BP started dropping. We started inotropes. Child went into bradycardia, and then arrest, resuscitative attempts failed, and the child died. So this was the whole story of 24 hours. So I thank ISA Borivali for giving me this opportunity to talk about this case where we could not save the child for the lack of a drug. Because what they say is that without the drug, mortality is about 60%. And with the drug, the mortality is just about 5%. So probably had we had the drug, we might have been able to do something positive for the child. Thank you.
Thank you, Dr. Abhi. Thank you very
Yeah,
much.
so just a line or two. Relatives were counseled that it was a malignant hyperthermia and it is a thing which is carried genetically and it would run in the family. So at that time, even genetic testing was out of question. Child was also from a low socioeconomic strata. They would barely able to understand what is happening. So we just told them that whenever any family member is undergoing the surgery, inform the anesthetist that such a thing had happened, that the child had a very high fever, and take the discharge card with them whenever anybody from the family is there. And one thing I started introspecting, could I have done something differently? One, probably a higher level of suspicion. We could have started suspecting malignant hyperpyrexia as Dr. Vikas Nayar's patient. They started suspecting it very early. So you should have a very high level of suspicion, which was probably we started suspecting a little later, but I don't think it would have made any difference in the treatment. Early investigations. Now, this is what we should be probably doing. Probably using the TIVA for smaller procedures. Say small procedures, we need not put an inhalation. Then suxamethonium, my usage now for less than 12 years is almost negligible unless I suspect any problems in the airway. So suxamethonium less than 12 years, and all these anorectal procedures which are even short duration procedures, we started doing under caudal epidural after that, so as to avoid the uses of suxamethonium. Thank you.
Thank you, Dr. Abdul. Dr. Garud to introduce the next speaker.
I invite next speaker, Dr. Ankit Desai. Dr. Ankit is an MD from Sion Hospital and worked at Wadia Children's Hospital. He is a founder of Children's Anesthesia Services, a group of pediatric anesthesiologists having practice in suburbs as well as Nanavati Hospital, Bridge Candy Hospital, Surya Hospital, etc. He has written few chapters in pediatric anesthesia books, multiple papers he has published, and he has a private practice of pediatric anesthesia for over last 15 years. So over to Dr. Ankit.
Am I audible?
Yes.
Yeah. Is my screen seen?
Yes, screen is visible.
Yeah. So greetings to all. Thank you to ISA Borivali, my home branch, for giving me this opportunity to present malignant hyperthermia. Before we begin, this is my disclosure. I have no financial liability. I am ready to confess that I have never seen a case of malignant hyperthermia, and I hope that I never see a case in my entire practice, because as we all know that anesthesia is 99% boredom, but 1% is panic, and these kinds of cases can be like moments of terror. So I hope I don't see such cases in my life. So malignant hyperthermia, what is malignant hyperthermia? Basically, it's a life-threatening disorder. It's a disorder with a hypermetabolic state. And since it involves drugs, it is also can be labeled as a pharmacogenetic disorder. And it is a disorder of the calcium dysregulation. So there is some amount of calcium dysregulation which causes most of the problems in malignant hyperthermia. So there are two things which are basically important. One is genetic susceptibility and other is triggering agent. So malignant hyperthermia can occur in individuals who are genetically susceptible to malignant hyperthermia in the presence of some triggering agents. Now there is something called as awake malignant hyperthermia, which we'll cover in the subsequent slides, where a malignant hyperthermia episode can be triggered even without a triggering agent. So what are these triggering agents? So triggering agents include a depolarizing relaxant like scoline, which was seen in the previous cases, and it includes most of the volatile anesthetics except nitrous oxide. All other inhalational agents can cause, including sevoflurane, desflurane, isoflurane, all can trigger an episode of malignant hyperthermia. So in genetic susceptibility, there are specific genes which are susceptible with the individuals who will have like it's an autosomal dominant disorder. So any disorder in these genes, 99% of the cases will have an RYR1 gene disorder, that is ryanodine receptor disorder, which regulates the calcium metabolism from the sarcoplasmic reticulum. Other genes are CACNA1S, TAC3, etc. And muscular dystrophies, especially the congenital muscular dystrophies, not the Duchenne's, etc., which are X-linked recessive. These are the disorders which are mainly implicated with malignant hyperthermia, which includes King-Denborough syndrome and central core disease. These are autosomal dominant disorders, and these are mainly implicated with malignant hyperthermia. So what are the statistics? So in USA, it is seen in around 1 in 5,000 to 1 in 15,000 children. The incidence is seen in adults, but it is slightly lower. That is, it's seen in 1 in 40,000. Remember, this is US data. So as far as history is concerned, the first case of malignant hyperthermia was seen, like there were many cases of unreported hyperthermia and exposure to anesthesia in family members where deaths had occurred. But this was when malignant hyperthermia, like it was realized that this can be a gene that is causing malignant hyperthermia. So this first case was seen at Melbourne Children's Hospital in 1962 and discovered by Denborough, where a patient had 10 relatives who had died and he had some tibia fracture, and this case was done under spinal anesthesia, and later some genetic studies was done, and then it was found out that this is some autosomal dominant disorder that is causing these reactions. So as far as India is concerned, before 2000, no cases were reported. Probably Avdut sir's case is before 2000, but it is not reported in literature. So as far as literature is concerned, the first case was reported beyond 2000. Before that, it was believed that Indian population is not susceptible to malignant hyperthermia, and various agents have been implicated, various age groups people have seen. But as far as like you can see this column over there here, this is a malignant hyperthermia score. So most of the diagnosis is based on clinical symptoms, and it is not based on the actual confirmatory test, which is a caffeine halogen contracture test, which is probably not available in India. So these are probably based on these scores, and an actual caffeine halogen contracture test is not done in these cases, and most of them have not received dantrolene. Only one patient has received dantrolene, and most of them have survived with the management. So if you see malignant hyperthermia susceptibility, it is twice more common in males. It is a not guarantee that it will happen. Even if an individual is genetically susceptible, it is not a guarantee that it will happen. It can happen with even one or two uneventful anesthesia. So if a patient is undergoing a third surgery, it can still happen in those patients, can happen in children and adults also, can happen as a first event before any obvious symptoms of muscular dystrophy. So it can be the like first sign where you will investigate and you will find that this patient has a muscular dystrophy. And there is something called as an awake malignant hyperthermia. So what is malignant hyperthermia? Basically, it is this RYR gene or ryanodine receptor gene which regulates the calcium metabolism in sarcoplasmic reticulum. This causes release of calcium, which activates these T tubules or transverse tubules. And this calcium metabolism hyperactivity causes excessive oxygen consumption throughout the body and excessive CO2 production, which leads to the symptoms of malignant hyperthermia crisis, which includes muscular rigidity, hypercapnia, hypoxemia, acidosis, rhabdomyolysis, hyperkalemia, and hyperthermia. So there are a number of differential diagnoses of malignant hyperthermia, which includes pheochromocytoma, then neurolap malignant syndrome, which is a syndrome which occurs in reaction to certain antipsychotics like haloperidol, etc. Then thyrotoxicosis, heat stroke, status epilepticus, even hypertensive crisis can mimic an episode of malignant hyperthermia. Now, as we said, certain muscular dystrophies, if you see Duchenne's muscular dystrophy, it is not an autosomal dominant disorder, it is an X-linked mutation. And most Duchenne's muscular dystrophy patients, they do not have RYR1 gene defect, but they have a syndrome which mimics malignant hyperthermia, which is called as hyperkalemic arrest. Like it's an acute hyperkalemic arrest. So in these patients, you mainly see an acute onset hyperkalemia and rhabdomyolysis. So it mimics an episode of malignant hyperthermia. No actual hyperthermia or muscle rigidity is seen in most of the cases. The triggering agents are basically the same. They are scoline and inhalational agents. But since it doesn't involve an actual hyperthermia, and most of the times this CHCT test will be negative in these patients, so it is not a true malignant hyperthermia, although the symptoms will mimic a case of malignant hyperthermia and the triggering agents are the same. So what are the symptoms? So symptoms include tachycardia, hyperthermia, skeletal muscle rigidity. Masseter is most commonly seen when scoline is involved. Then tachypnea with increased ETCO2 especially, which is not settling down with an increased respiratory rate and increased tidal volume. Then you will gradually have hyperkalemia, which can be the first cause of death in these patients, and acute hyperkalemia. Then you will have metabolic acidosis, myoglobinuria. Patients can go into DIC, death, renal failures, etc. So immediate life-threatening event is an acute rise in potassium, and you will see various patterns. At 6 potassium, you see loss of P waves, then you see wide QRS, and then patient will go into VFib, etc. So the other complications that can occur are hyperthermia, DIC, multi-organ failures. Then there are certain late onset syndromes like acute renal failures. Sometimes malignant hyperthermia can be seen at a later stage, maybe after say a day or two, even after exposure of anesthesia. And mortality can be 5 to 30%, even with dantrolene use, can be far higher if dantrolene is not used, and the use of dantrolene is time sensitive. So earlier you give, the better the prognosis is. So what is the treatment? Now, the treatment will involve discontinuing the agent, and you shift to T1 if the procedure is to be continued. If the procedure can be stopped, you inform the surgeon and you stop the procedure and discontinue all anesthesia agents. Then 100% O2, they call for help, dantrolene as rapidly as possible. Then you will use various measures to cool down the patient to get the patient less than 38 to 39 degrees. So you can use cold lavage, ice application, rectal enemas, etc. Then you treat the various complications that are happening. So metabolic acidosis you treat with soda bicarb. All dysrhythmias can be treated for their specific treatments. Remember, dantrolene, if used, calcium channel blockers are absolutely contraindicated. Dantrolene and calcium channel blockers cannot be used simultaneously. Then hyperkalemia, you can treat with bicarbonate, calcium chloride, glucose insulin drip, monitoring as per the case, and post-acute phase care. As we have seen in the previous cases, you may have to monitor the patient for 2-3 days or even longer, even after an episode has occurred. So how does this dantrolene work? The dose of dantrolene is 2.5 milligram per kg. It is repeated every 5 minutes. An upper limit, some books say it is 10 milligram per kg, but if the hyperthermia persists, there is no upper limit to the dose of dantrolene. And later, once the episode is controlled, it can be the maintenance dose is around 1 milligram per kg every 4 to 8 hours. Monitoring should be continued. Dantrolene, how does it work? It is a specific ryanodine receptor 1 antagonist. So it acts on these receptors and prevents the release of calcium, which is the main implicating agent, or which is the one which causes all the symptoms of malignant hyperthermia. So now ryanodine receptors, these are of three types basically. RYR1 is the specific type which is available in skeletal muscles. RYR2 is present in the cardiac muscles, and RYR3 is mainly present in the brain. So dantrolene acts specifically on these RYR1 receptors. So now RYR1 receptor, which acts on the skeletal muscle, is the cause of malignant hyperthermia. If there is an RYR2 mutation, then it mainly causes cardiac arrhythmias, and RYR3 mutations are mainly implicated with Alzheimer's. So malignant hyperthermia, here we are concerned with the ryanodine receptor 1 and receptors. So now coming to dantrolene, there are two types which are available. One is dantrium, which is a 20 milligram vial, and other is Rhinodex, which is a 250 milligram vial. So this 20 milligram vial has to be diluted with 60 ml of saline. It is very difficult to reconstitute. You need 60 ml. Sometimes you may have to use some warm saline so that it can be dissolved quickly. This has to be diluted only with 5 ml of normal saline or distilled water. This is easy to reconstitute, and one vial is 250 milligrams. So say if you have a 50 kg adult and the first dose is 2.5 milligrams per kg, so this dose comes to 125 milligrams. So you will have to rapidly dilute around 6 to 7 vials of these. Whereas with this you can give the first dose and also give a second dose with the same vial. So this is a bit costlier than this also, but I think this is the one which is available at most of the places. Now, shelf life, logistics, etc. I think we can discuss in the next lecture. Nandini madam is already covering it. So, as far as dantrolene is concerned, it's like the time period or the earlier you give, the better is the result. They say it's around the complication rate increases by 1.6 times for every 30-minute delay, and beyond 50 minutes, the effect of dantrolene is not very good. So it has to be given in the first hour. So as far as prevention is concerned, like many times you may have a patient who is, it is susceptible to an episode of malignant hyperthermia. So how will you prevent them? So basically what is recommended is volatile anesthetic concentration should be less than 5 parts per million. There is an overnight degradation of volatile anesthetics within the circuit and the workstation. So it always has to be taken as the first case in the morning. When you are doing the case, remove all volatile anesthetics from the workstation. If it can be removed from the workstation, it has to be removed so that someone doesn't inadvertently start the vaporizer. New circuits, mask, absorbents, etc. should be used. New workstation, if available. Some hospitals have a specific workstation available which doesn't have any volatile anesthetics attached to it. So if it is available, you can use such a workstation for these cases. Now you have something called as a vapor clean charcoal filters. These are basically charcoal filters which absorb all the volatile anesthetics from your closed circuits. So these, if available, should be available in your malignant hyperthermia cart. These are very good for these kinds of cases. They are available in most of the US and European hospitals where malignant hyperthermia carts are available. So basically, what are the recommendations? There are 4 ways you can use the workstation. First is if you are using charcoal filters, then only a 90-second flush with 10 liters of oxygen is adequate to remove all the gases. Then there are certain workstation specific instructions, like certain workstations you may have to flush for say 1.5 hours. Certain workstations you may have to flush only for 20 minutes. So you have to see the recommendations in your workstation to completely flush out the volatile anesthetic. If available, a dedicated vapor-free vaporizer should be used if it is available at your place. And if appropriate, you can get a ICU ventilator to do your cases because they are never exposed to a volatile anesthetic. So these are 4 ways you can use a workstation in your cases to prevent an episode of malignant hyperthermia. So there is something called as a malignant hyperthermia cart, which should be available in ideal scenarios. I know most hospitals don't have it, but ideally you should have this malignant hyperthermia cart. So what does this malignant hyperthermia cart contain? It should have dantrolene, which is at least 700 milligrams should be available. Then NS or distilled water should be available. Insulin, dextrose, etc. for to manage the hyperkalemia. Soda bicarb, calcium gluconate to again to manage the metabolic acidosis and the malignant and the hyperkalemia. Lignocaine to manage the arrhythmias. Furosemide for the renal failure. It should also contain your charcoal filters, syringes, 60 ml syringes should be available to quickly dilute your dantrolene if available. Then ice packs, pressure bags, lab sampling supplies, all this should be available in your malignant hyperthermia cart. Or when you are doing the cases, make sure that you make these things available. Now, if you saw the first Indian slide where there was a clinical grading scale. So there are certain clinical grading scales depending on the symptoms, which include muscle rigidity, myonecrosis, then CPK levels, PET, CO2, etc. So these are the grading on the basis of which we make a diagnosis of malignant hyperthermia. Since the confirmatory test CHCT is not available at our place, so this is how we diagnose it. So basically, if the score is less than 20, it is very unlikely that it is a malignant hyperthermia. And above 50, it is almost certain that this is a malignant hyperthermia. So whenever you have this case, try to put them in these kinds of classifications. And if it is very likely or almost certain, then in these patients, you need to give dantrolene. So these are our 6 cases again. If you see, they are most of them have happened. The reported cases at least have happened in adult patients. Most of them have exposure to inhalational agents only. Most of them have survived. Only one had received dantrolene, but most of them have survived. But one thing that has not been done in any of these cases is a confirmatory test, that is a CHCT. Also, genetic studies post this exposure is not done in any of these cases. There is no report of tests being done in these cases. So what is the confirmatory test? Now the confirmatory test is in vitro caffeine halothane contracture test or the CHCT test. There are different guidelines in North America and Europe. They follow different guidelines. So basically, depending on how they contract, they take a sample of muscle. The sample of muscle has to be taken in that particular institute since this muscle tissue cannot be preserved. So anesthesia, etc., has to be given in that particular place where the test is happening. You need a large sample of muscle. Then it must be done at the site, and if there is an episode, then it has to be done after 6 months of the episode. So they are categorized. So they are exposed to caffeine and halothane, and the contractures are seen. And depending on that, you have 3 categories. That is malignant hyperthermia susceptible, malignant hyperthermia neutral, and malignant hyperthermia equivocal. So MHS is when there are contractures positive to both caffeine and halothane. MHN in when there are is when there are no contractures for both caffeine and halothane, and MHE when there are contractures to any one of the agents. So that is how you classify these malignant hyperthermia patients. Now at many of the institutes, since halothane is not available very freely, so they are shifting to sevoflurane. So now you have something called as a caffeine sevoflurane contracture test since halothane is not available. So as we discussed initially, there is something called as an awake malignant hyperthermia. So basically, there is no exposure to any of our anesthesia agents. They have an RYR1 susceptible gene. It is genetically proven that they have malignant hyperthermia, but they have a similar kind of response like our malignant hyperthermia response. But the response like it is happening to exercise or emotional stress. So no anesthesia agents have been inhaled, but only to exercise and emotional stress, they are developing these symptoms. Hyperthermia and other signs are also seen, and some of these patients have even responded very well to dantrolene. So there is another entity which is called as an awake malignant hyperthermia, which also you should keep in mind. So in summary, you remember there are 2 things that are involved. One is genetic susceptibility and triggering agents. Dantrolene is the only specific treatment available for these reactions, and its use is time sensitive. It should be given as quickly as possible. There are a number of other conditions that mimic it, and caffeine halothane contracture test is the only definitive diagnosis of malignant hyperthermia, and there is something called as a malignant hyperthermia card, which you should try and make it at your institutes. Thank you.
Thank you, Dr. Ankit, for an excellent presentation. We will have a lot of questions to be answered in the panel discussion. Now I call upon Dr. Nandini Dave, madam, to speak on the logistics of dantrolene. Dave, madam, is the undergraduate of Borivali Medical College. She has multiple postgraduate qualifying in allied specialist branches of anesthesia, with more than 100 publications to her name. She has authored chapters in anesthesia textbook. She is the editor of Principles and Practice of Pediatric Anesthesia. Currently, Madam is a senior consultant and head of the department at NHRCC Children's Hospital, Mumbai, Vice President of Indian Association of Pediatric Anesthesia. She has university teaching experience of more than 20 years. She is recipient of various awards and honors and a regular faculty and guest lecturer in different conferences and workshops. I welcome Dr. Nandini Dave, madam, to make your presentation.
Yeah, am I audible now?
Yes, madam.
Thank you. And is my screen visible? Is my screen visible?
Yes, madam.
Yes, madam. Visible.
Yeah, thank you so much. And thank you to ISA Borivali for this privilege. So let me take you through my story. I think there's a background. Shall I continue?
Varsha, madam, please mute everyone. Varsha, madam. Ganesh.
Okay. Yeah, hello. So let me take you through my story. It actually begins way back in 2008. So I was in Nair Hospital, and we had this child who had come for a hernia surgery, simple open hernia surgery, 4-year-old, absolutely healthy boy, no comorbidities, no history. We did the case under LMA, and I remember we had used sevoflurane. Surgery went on, got over in about 40-45 minutes. And I must confess, during that time, we were not using skin temperature for short cases, so we were not monitoring temperature. Intraoperatively, things were okay. End of the case, we removed the LMA. And then we noticed that the patient was drowsy. And, the temperature was high. When we actually touched the patient, it was high. It was more than 100 degrees. There was no other reason for the fever. So we thought maybe whether it is MH, we didn't have dantrolene, of course. We sent the blood for CPK, started cooling measures. CPK levels were more than 1,000. This patient actually did well. With the cooling measures, he responded. He went home. And at that time, I remember we wrote a letter to the editor. And this was published in IJ. And interestingly, if you look at, if I Google this, there is no mention of this correspondence in IJ. You won't find a soft copy. So I found that it is, like how we think malignant hyperthermia doesn't exist in India. We don't see it in our kind of patients. So somehow this letter also has got lost somewhere. And we had made a recommendation for dantrolene and continued vigilance. And I thought that time we must monitor temperature during surgeries. So this was way back 2008. After that, actually, I continued, of course, my practice. And then in 2019, I moved to SRCC Children's Hospital. And what changed for me was that my spectrum of patients I saw changed considerably. So I started doing a lot of, these children, a lot of significant orthopedic cases with deformities. We had children who were syndromic, and we had children with myopathies, most of them who were not tested. But we also had children who were tested, and we had children coming to us with a proven RYR mutation, and we didn't have dantrolene. So when I started my practice at SRCC, I thought, 4 years ago, that we must do something and we must try and acquire dantrolene. It took some time because the next year COVID started, and people were not interested in spending money for, dantrolene, especially a drug which had a short shelf life. We don't know how to acquire it. We don't know where we would get the money to buy dantrolene. Nobody really was interested. So there comes a turning point for everyone, and this was my turning point, where we had a sort of a meet which we have an annual meet. It is called NH Chronicles. NH stands for Narayana Health, and we all come under the NH umbrella. So my fellow Vinisha, she had presented a paper on malignant hyperthermia triggers, and we made an appeal for dantrolene at this presentation. Incidentally, we got the prize for this presentation. And basically, here we presented a case. This was a 4-year-old male child with proven central core disease who was posted for major orthopedic surgery. He had history of developmental delay. He was hypertonic. He was genetically tested and proven to have the RYR mutation. He had no previous exposure to anesthesia, and all this routine investigation, including the CPK levels, were normal. So we knew that we had a problem child, and we planned trigger-free anesthesia. And what happens when we are dealing with patients and parents is that we still have to explain to them, we don't have dantrolene. Your child could have, despite trigger-free anesthesia, your child still can have, a malignant hyperthermia crisis. And just like Dr. Ankita also explained, even when you use trigger-free anesthesia, you could have maybe just the surgical stress which could cause MH. We don't know. So this was our story. We were telling patients that you could have an MH risk, and we still don't have dantrolene. So that was a problem. So MH in India, the problem is we don't report. So we have a significant amount of underreporting, and I'm very sure of the fact, because I have sometimes friends who call and say that, okay, we had this patient and he was febrile post-op. I've had friends saying that we have lost patients after anesthesia, and it's not reported. We don't have a national registry. We don't have genetic testing for most of our patients. We don't have diagnostic tests. Even today, we don't have the caffeine contracture test. And of course, there are economic constraints. Who wants to spend for anesthesia? Who wants to spend for a drug which has got a short shelf life? And especially, it's like kind of a proposition where you're happy to not use the drug. So you're happy to spend that amount of money and don't have to use it. So people don't want to spend like that. So this year in April 2023, finally, after a struggle of more than 3.5 years, we managed to procure dantrolene. So how did we do it? Our fellow, Vedika was doing a fellowship with us last year, and with a generous donation from her family through CSR funding, we managed to get the donation. And then began the struggle of finding how to, we had the money, and then we didn't have, a stockist who would be able to supply dantrolene. So we got it through, it is imported. There is no import license. We don't have the facility to procure it. So we pay a huge amount of import duty. So this is what we have right now, a pack of 12. It cost us 2.7 lakhs, inclusive of GST. So roughly it's about 22,500 per vial. And the shelf life is 2.5 years. So to take you through the process, finding a stockist. So I was actually calling up across the country, calling up people who I thought, had access. So I called up Ganga Hospital, Dr. Bala to put me through a stockist in Trivandrum. There was another stockist I found in Delhi. But again, what happened is during the whole COVID process, people were going into losses. Whatever dantrolene they had expired. And it was quite a struggle. At one point we had the donor and we didn't have dantrolene still available. So,
she fight too.
Yeah. So basically we were, I was literally running.
Basically, we all met first.
Okay. So yeah, I got some trouble finding the stockist, but finally managed to track down a person in Trivandrum, and he agreed to procure the drug for us. So finally, the paperwork for actually procuring the dantrolene became simple, because all you need is a prescription on an official letterhead. You need the patient's name. You need the Aadhaar card. In our case, also the parent's Aadhaar card, because the child was a minor. And you need to transfer the money prior to the import, because nobody is going to work on losses. So we had transferred the amount, and I was hoping that we'd get the dantrolene after transferring this large amount of money. And then within about, I think it took us about 3 weeks, and we got the delivery. So we have dantrolene. We have dispersed some of it to our colleague who had a case of malignant hyperthermia in our city. But the questions that remain for us is, how do I ensure a constant stock? Because I have 12 vials. I have dispersed 4. I have 8 now. How do we have a constant, how do we have a system of disbursement? If somebody asks me, an adult is going to need 12 vials, it's an ethical dilemma, because my hospital will be very reluctant to give all 12 vials out, because if the next day I have a patient, I don't have stock. So, and again, the issue of payment, it was the first time somebody asked us and we gave it out, and we didn't have a system because we had got it through a donation. How do we take? So our thing was, how do we get the money back? So the patient paid, they came with us, they came to our hospital, they came with cash, they paid, we gave out the dantrolene. That's how we did it. But these are the questions that, constantly are arising in our mind. Incidentally, what happened was just last month, we went through our JCI accreditation process. We got a JCI accreditation, actually. That's Joint Commission International. We are already NABH accredited. So one question the JCI inspector asked me when they came on the OT tour is, do you have dantrolene? So I was actually very happy to say that we do. And the next question they asked was, have you done an MH drill? So we had it. So their recommendation was that we do a malignant hyperthermia drill, because in the event we have an MH kind of crisis, how are we actually going to go through the process? And that's something which I need to do. It's still on the to-do list. Like Ankit said, it takes a considerable amount of time to actually reconstitute the dantrolene. What happens if it happens out of hours? Like say in an emergency evening situation, our dantrolene is under lock and key in the basement because it is an expensive drug. How am I going to actually ensure that I get it quickly? So I have to call the pharmacy, maybe call my facility director, ensure that that key is there to open it, get it up, because it is all time sensitive. And so that's something which we all need to do. And I still don't have an MH card for the rest of the things. I know the drugs are available, but I think the next step would be probably to make an MH card, considering that we have dantrolene. So the need of the hour, I think, is we need to increase awareness. For me, it was telling all the pediatricians, because it's no point just talking about, of course, it's important that we talk amongst ourselves, but also we need to let our surgeons know, we need to let our pediatricians know, we need to let our hospital administrators know that any anesthetic, there could be a risk of malignant hyperthermia. And dantrolene needs to be available. Not just one hospital in the city having doesn't make sense, because we don't have enough to disperse. I had a case that just the next week I had a call from Pune. That patient, I think, succumbed to malignant hyperthermia. And we couldn't supply it to Pune because we were already at that point of time, we had given out 5 or 6 vials. We had only 6 vials with us. So we need to have a national registry for reporting cases, because once we make a noise, that's when, the authorities will say, okay, we need to make it available. We need to make, and we need to work with the government so that we can legalize import. And there are various organizations who are, with you have organizations for rare diseases, and there is a registered organization in India also. And these people actually work to see how we can make the import legal so that we don't have to go through the gray market and increase the cost for us. So yeah, that's my story, and thank you for this opportunity. And I'm happy to take any questions.
You will have a lot of questions, madam. We'll
Yeah.
take the questions in the panel discussion. Dr. Garud will introduce the next speaker and the panelists. Then we start with the panel discussion.
Thank you.
Our next panelist is Madam Dr. Kalpana Kelkar. She is a professor and HOD of Critical Care Medicine at D.Y. Patil Medical College. She has also worked as HOD of Emergency Medicine at KM Hospital, Pune. She is retired from BJ Medical College as professor and head of the Department of Anesthesia. She has also handled post of Deputy Dean of BJ Medical College for 3 years. She is a winner of many awards for best paper and poster presentation. She is a member of Postgraduate Board of Studies of MUHS, that is Maharashtra University of Health Services. She has many research publications at her credit. She's examiner for DA and MD at various universities. She is a governing council member of Maharashtra chapter of ISA and member of medical legal cell of IMA Pune. She has received Lifetime Achievement Award as well as Hall of Fame Award at Ganga Hospital. Over to Madam Kelkar, please.
Hello. Thanks for that introduction. I must congratulate Dr. Nalini Dave for that for the efforts that she has taken. And when she was referring to the case from Pune, it was the case which had taken place at D.Y. Patil College where I'm working just now. Now I'm working in the critical care medicine department, but this case happened in anesthesia department and the patient was shifted to us after, uh, when she was diagnosed to be having malignant hyperthermia. So surgery was abandoned and she was shifted to the critical care. And unfortunately, we could not save her. She had all the features of classical malignant hyperpyrexia. And actually, really speaking, I have seen one case 20 years ago, uh, 25 years ago, when this patient had a difficulty in swallowing. Should I go ahead or should we go with ahead with the panel? I would like to know.
Madam, I
Madam,
think you
please,
can.
please go ahead, madam.
Yeah,
Madam,
please go ahead.
Yeah. So we had one case. The patient had difficulty in swallowing. So patient was posted for esophagoscopy. And after giving thiopentone, those days we were using thiopentone regularly. Propofol was not there. Thiopentone and saxamethonium, she failed to relax. Now, unfortunately, I did not know. We always know about the halogenated hydrocarbons, but I did not know that even diethyl ether is contraindicated in cases of suspected MH. When she failed to relax, I thought that I will take her deep with diethyl ether, and the ENT surgeon said that we will put the scope inside and we will see. There is no need of intubation if patient is not relaxing. And so I took her deep with ether. Again, she failed to relax. Somehow we could complete the esophagoscopy and there was nothing abnormal there. So probably it was a case of Plummer-Vinson again coming back to the myopathy problem. So it was a muscular problem. And later on, this patient developed ankle clonus and cogwheel rigidity. And patient developed runs of ventricular ectopics and a ventricular tachycardia, which we had to treat with Xylocard. We kept saline in the fridge. There was no question of dantrolene because dantrolene was really unheard of in the Indian subcontinent. But luckily for us, the patient never developed hypothermia, and luckily for us, the patient came out just with cooling. So that time onwards, and then afterwards also, I had received so many phone calls from all over Maharashtra. People asking, Madam, Dantrolene hai ka, because we have such and such case. And we could not get hold of it. So I was trying very hard for this Dantrolene. We had one case, one of my students had a case of post-operative query malignant hyperpyrexia in a child, which again had a favorable outcome. Uh, so we were trying very hard for this dantrolene. And after this case, which took place at Diva Patil, where I am working now, I really gave a very serious thought. I had actually, in one of my orations in 2018, I had suggested that as a branch, we should do something. Like Dr. Dave pointed out, it is very difficult to convince the hospital to have such an expensive drug, which has got a shelf life of 2 years. And if we don't have to use it in 2 years, then we have to go again for another set of vials. So what I thought, okay, if that is my idea, whether now since Bala has got elected as the president elect, let us see in his tenure or even in Jigi's tenure, if we can do something at the national level. I'm thinking of having something like, this is my idea. I don't know, people can comment about the difficulties and problems if we have to go ahead with it. But I thought that how we pay the insurance premium. Similarly, all the city branch members can come forward and can donate money. See, it is only the question of 2.75 lakhs divided by the number of anesthesiologists practicing in that particular city, so that we can have one set of vials available in any one hospital, which can be given to any person who comes across this problem in one city. I understand that the distances in the metro cities are more and it might take more time, but it is better than not having it all together. So that is my idea. Ki suppose, because see, nowadays, even if we do a pizza party, we are spending such a lot. So why not spend just 1,000 rupees or say 2,000 rupees once in 2 years for a dose of dantrolene, which can be available and with which we can save the patient. So what does the August gathering think about this proposition? I mean, is it possible to go ahead with it? Dr. Dave, what is your take on that?
Madam, we will discuss this in the panel discussion, madam. This is one of the points we would like to take up in the panel discussion.
I can't hear.
Madam, we will
Madam, we
discuss
will
this
be
in the panel. Yeah.
Madam, he's saying we'll
We
take
will,
it up in the
we
panel
will
discussion.
go on to the panel discussion,
Yeah, sure,
madam.
sure. Yes, yes.
Yeah,
Okay.
Dr. Tej, can I start the
yes.
panel discussion?
Now,
Yeah.
Dr. Tej to.
Yeah. Now we'll be starting with the panel discussion. The panelists are Dr. Ankit Desai, Dr. Nandini Dave, Dr. Shilkar Madam, and Dr. Abdul Tripathi. Moderator will be Dr. Shilpa Tivaskar. Dr. Shilpa is our immediate past secretary of ISA Borivali, the most hardworking secretary that we have had. She has been a colleague of mine during our PG days. Extremely good in academics and very down to earth and always willing to work for ISA. Shilpa, please start the panel discussion with the question. Thank you.
Dr. Tej, thanks for that intro. Yeah, welcome all the panelists. Is Dr. Vikas Nair also? Sir is there? Dr. Vikas Nair, sir? Okay. So the first question.
Yes, I'm here.
Yeah, sir. So for you, I wanted to know from where did you get dantrolene?
So initially there was a lot of a little, you can say, time lost in the diagnosis or the provisional diagnosis. Then the next day, unfortunately, I was not in the institute, but I was told that the relatives could finally get the dantrolene with the help of Dr. Nandini Dave from SRCC.
Okay.
So
And
thankful to Dr. Dave and the institute.
yeah, thanks, Dr. Nandini, madam. Sir, so what are the cases what we have heard other than Avdut sir's case, and what are the recent cases which are there reported in literature? So malignant hyperthermia gives us some time to procure dantrolene and give it, right? It also gives us time to do symptomatic treatment.
Correct.
Like Nandini madam, you said that it is in lock and key and it takes time. But what are the cases which are discussed? So what I have gained is maybe it gives us few hours to react. So what would you say on that? Like how early should it be available? Whether 2 hours, 5 hours, or there is some criteria that once the fever sets in, or once there is arrhythmias, or once there is myoglobinuria, then it should be immediately given? Or what is any criteria? How early and after what time it is of no use? Like in Vikas Nair sir's case, it was given on second day. So what I want here, see, most of us are private practitioners, okay? So by the time dantrolene is got, whether the symptomatic treatment really helps and we should continue. So
let me tell you, initially we did not know about SRCC and the dantrolene that they have managed to procure. So the relatives went here, there, as Dr. Avdut said, Noble Chemist, which is our first stop for getting all such medicines. And then finally we came to know of SRCC and Dr. Nandini Dave. So I think by the time we got the dantrolene, it was well past 26 hours. And at the end of 26 hours, then again there was a question whether it will be of any use at all to give dantrolene. But we all decided that since we have and there is no harm in giving it, we gave dantrolene. unfortunately, immediately after that, the patient developed nausea, vomiting, and then the LFT started getting deranged. It could have been because of the malignant hyperthermia per se, but then the nephrologist and the intensivist who were treating it said we have already have problems with one major organ, that is the kidney, and since we don't know or see a major good effect of dantrolene to be given now, they withheld the dantrolene as the maintenance dose. So they gave only the loading dose, and then they said, let us wait and observe. So coincidentally or otherwise, the CPK immediately started falling down the next day.
Yeah. So Kelkar madam, what do you think? Yeah.
Yeah. See, actually, it depends on the severity of the symptoms of the case. Like when this case was discussed, it was a post-operative case. But the case which I have witnessed, the course was so uh, dramatically progressing ahead. It was really a matter of minutes when the BP was rising. When the patient was brought to critical care, she was not having rigidity. So my anesthesiologist colleague, she was saying, "Ki, Madam, bromocriptine we will try. Is it really MH?" I said, "It is MH. From all the symptoms, I feel it is MH. We must try and get dantrolene." And we tried really far and wide, but there was the time available was very short. Even a chartered flight from Coimbatore, it was available at Coimbatore, but the chartered flight also could not give us the drug in time. So it was impossible. So we have to have that within the city, and earlier we get it, the better. And actually, we haven't used dantrolene. We don't have our first-hand experience. But what I remember from one conference in Sholapur in 2004, Dr. Rebecca from where
Vellore.
Vellore, yeah,
Mm.
she had said that she had treated one case of MH in Middle East, and or in UK, I think, and she said that the patient was so stiff, the hand was like this, and when I started injecting the drug, the heart relaxed. So it is that far. Yeah. So it is a very dramatic recovery. So earlier we get it, the better, definitely. And to have earlier the better, we have to have the MH drill, and we have to be geared. We have to have a sort of hotline number within that city. If there is a case, suspected case, then we should contact that hospital immediately, and there should be channelization of providing that drug very fast. I think that is very necessary if we really want to make uh, good use of that wonderful drug.
Yeah, yeah. So, Nair sir, in your case, you said that the resident went back to his, I'm sorry, the patient went back to his city. So, do we have DNA testing done in Mumbai somewhere, or
I think Dr. Nandini will be better
Nandini
person to
madam?
answer.
Yeah, genetic
I can
Genetic.
tell about this, about genetic testing, if you don't mind.
Yeah, please, madam.
Yeah, recently we had a case in Kokilaben Hospital, and that time we had done the genetic testing. We had sent the sample from our hospital, but it had gone to Narayana Health Center in Bangalore. And it took almost 1 month to come the report.
Oh, so
So it
Nandini
is
madam,
not happening in Mumbai. Yeah.
Nandini
No,
madam can throw
testing
some light.
is happening. There is MedGenome. There are many centers in Chennai, Bangalore. I believe even in Mumbai it is there. So we get patients who are, come with genetic reports all the time. So it's quite common because we get children with so many other, congenital, sort of problems that it is not uncommon for them to come with a genetic testing report. Yes. So I've seen at least 2 patients in the last 4 years who had proven RYR mutation.
No, what I mean to ask,
Can I,
like, if I'm a
can I,
private practitioner,
can I
and
say something?
yeah, yes, madam, sorry.
Yeah. Recently, the case which we had, there also we got the genetic testing done. And as both the speakers initially said, the labs are down south, but the collection centers are there. So we had one collection center at Pimpri. We contacted them, we paid the money, and it is not a very prohibitive cost. We got it done at 20,000 rupees that we had paid from our pocket, and then we collected and give it. And then the sample, we got the result within 8 days. We had to be after the report, but then we got it. And there was RYR1 mutation. So then we counseled the family, and we are going to get the members also screened for that. So then genetic test is luckily now available. So
Yeah, good. So at least we can have some center in Mumbai, which can collect the sample.
Yes.
Yeah, but at present we don't have any lab in Mumbai who does that testing.
I think
No,
so.
I
There is
think
no lab, but it's okay. It's not such a big deal as long as the sample is
Yeah,
collected.
because
The result.
can I?
yeah,
Because
yes, yes.
the emergency is not diagnosing. I mean, even
Yes.
if you diagnose after a few days, it is okay because
Correct.
it's not going to change the management as such.
Yes, yes.
Yes.
Yeah, it is
Uh,
only for the family and for the
Yeah.
further thing. Yeah.
yeah.
So
Again,
actually, there are two teams needed. One to look after the medical aspect, and the second to calm down the agitated relatives. Because for them, this is a patient who is walking into the OT, and now we are all explaining that he's critical and
Absolutely.
most of his organs are, deteriorating. So that is another thing that we all need to take care of.
And here there is a very important consideration which we have to take into account, that when we are taking the consent of the patient, malignant hyperpyrexia is so rare that normally we never mention that to the patient's relatives, isn't it?
Correct.
So should we have something to include it in our pre-op consent, though it is extremely rare, but some such complication can take place, something of that
So
sort. That
Dr.
that's
has to
what
be
I
given a
wanted
thought.
to ask because now there are drugs which are implicated in MH and we are using them every day, day in and day out, left, right, and center. So patient may just say that if you knew that, see, any patient can Google this, and if they know that, you knew these drugs cause this problem, why did you use them at all?
Correct.
yeah, so
Feel
that's a
just
very
like
good
if
suggestion.
abroad and in centers in UK and US, they say that any place where you're giving anesthesia, there should be access to dantrolene. That is what they say. And
Correct.
we have patients who can pay. For them, 2.5 lakhs is nothing. Only we
Yeah.
don't bill them. That's not right, I feel. So I think that it is imperative that we should have access. It's just like initially when capnometry came, I mean, I'm talking about 20, 25 years back, everybody didn't have it and we were doing cases without capnometry. Now it is unthinkable. It isn't. So just like that, I feel it's time we have access. There is no other way.
And it's time that, like, ISA made defibrillator a mandatory monitoring equipment. Similar to that, I think some stand has to be taken so that we can make it mandatory and we can include it. Even though it is rare, we have to mention that it is rare, but it can happen that way. And especially in those cases where, like where you are working, there are lots of cases which are predisposed to develop this complication. There it is very easy to explain. We can always say in these cases there is a chance, but it is a problematic thing when it happens in a person who doesn't have any history whatsoever at all, and then it can be a problem, isn't it?
So
So we have to have
the
some.
problem, madam, is the undetected, untested cases. Most of the kids will still be untested. Who does genetic testing for every case, no? So when they come with a proven report, I'm actually a little bit happy because I know that I can use trigger-free anesthesia, explain the risk.
Yeah.
But the untested are the majority. I mean, 95% of my patients are untested. So I feel like your
Yeah, and
suggestion.
for that we can't just have a blanket thing that you should go for TIVA and should not use any. That becomes a
What
very
we do,
drastic step, isn't it?
agreed, madam. But whenever we
Yeah.
have even the remote sort of suspicion, we go for T1 nowadays because it's available. We
No,
have
no,
it.
that is fine. For pediatric cases, I accept. But what about adults? It is not that in adults the cases are not seen, na? So
Yeah,
what to do? Yeah, practical.
so as Kelkar madam said, what Kelkar madam is probably pointing at that not only the children, syndromic children or normal children, but the normal adults in whom the
Yeah.
cases have been reported. So the take home message is it should be available in each city. Maybe in Mumbai, we need at 2-3 places. So it is easily accessible and we should include it in the consent. Avdut sir, regarding your case, you said the baby was unconscious after say 5 hours, 1 hour of fever, and after 3-4 hours of struggling to know the cause of fever. So during that unresponsive. So during that time, was the baby intubated? You
No,
actually,
baby. No, baby was maintaining saturation. Baby was maintaining saturation. Baby was given nasal oxygen. So
yeah,
there
so
was no baby was not intubated at that given time. We intubated the baby only when we did the blood gases, came to know that baby has hypercarbia and this. So blood gases also we did quite late. So we did not do them as early, probably.
so maybe retrospectively, if
Yes.
yeah, it is your too. Yeah. Dr. Ankit sir, Regarding the charcoal filters, where they are available and what is the cost about? Like,
They're not available in India. I'm not sure about the cost.
yeah. So at present, they're not available with
Yeah.
us. Yeah. So before, I have some 2-3 cases which have been reported in literature. Before we quickly go on to them, can I request Dr. Chandni madam to take some chat box questions regarding for the speakers? Chandni madam, are you there?
Can I make a quick comment?
Yeah, please. Yeah.
Yeah. So previously, what was happening was, like Nandini madam said, that we are doing a lot of similar cases where we suspect or we may think that these patients may develop malignant hyperthermia. So previously, when it was not available anywhere in Mumbai, we were justified in doing these cases at any of the nursing homes or any of the hospitals where dantrolene was not available. But now, since it is available at one place, so now I make it a point that I explain it to the patient that it is available at SRCC and you have that option of going to SRCC and doing the case over there. So I have done this for a couple of cases. I have referred them to SRCC because it will not be available even if if the reaction happens and someone is getting the drug from SRCC, it is still very late. So rather, it is always better that the anesthesia is given in SRCC itself. So a couple of cases I have referred to SRCC, although the surgeon was not very happy about me doing it, but I have done that. So we always have that option of doing.
So have you referred children with myopathies or syndromic children?
Syndromic children where I suspect that a reaction can happen, or in nursing homes, it is very difficult to give trigger-free anesthesia. Some amount of drug is lying everywhere, like a volatile anesthetics. You are never too sure. So it is always better that you refer it to a place which are better equipped to manage these kinds of cases.
Yeah. Chandni madam, are you there?
Yes, ma'am. Good
Yeah. Can you go
evening,
for
ma'am.
the
Good
chat
evening to
box?
everyone.
Yeah, thank
Yeah. Yes, madam. We have a few questions. First,
Madam, you are not audible. Chandni madam, you are not audible. By the time Chandni madam gets ready, Ganesh, can you
hello,
project
am I audible now?
Yeah, you're audible. Yeah, please go ahead. Yeah.
I'm audible now? Okay. The first question is for Dr. Deepti. The first question was the patient an Indian national? She has answered it in the chat box, but if she could answer it on screen as well. I think she's not available.
Yeah, madam. Any other questions?
Yeah,
Yeah, the second question was.
Hello.
The other question was she was answered.
I had asked this question specifically because out of my span of 25 years, I've seen two patients. Out of that, one was an Arab national and the second was UK national.
No. So this is an Indian patient, madam.
Yeah. Okay.
The second question was whether any muscle biopsy was done in this particular case.
Hello. Hello.
Yes, sir.
The muscle biopsy was done.
Muscle biopsy was not done.
All right. The next question was from where dantrolene was procured at your institute.
No, you're.
So this was imported. This was imported from a UK-based company. I got in touch with a stockist in Trivandrum, and he imported it for me. This is from UK, from Europe actually. So it's a company called Norgine Pharmaceuticals, and the thing is that they will give you the whole pack of 12. You have to buy the whole pack. He will not sell loose or anything. It is available only in the grey market. So we pay a lot of import duty. Whatever cost he says, you have to pay. You can't do anything. That's it.
Thank you, ma'am. The other question for Dr. Deepti was on which day the patient was discharged, and there was another question regarding ETCO2 status and ABG trends or other.
Hello.
Yeah,
Just Dipti.
what day the patient was discharged?
On second week, patient was discharged from the hospital, and after that, till the third week, we are following the patient. So after 2 weeks, patient got discharged from the hospital.
Chandni madam, your voice is resonating, Chandni madam.
Okay, I don't have anything else. Is it better now?
Okay. Yeah, better.
What was the ETCO2 status and ABG status? That is also a question that has been asked to Dr. Deepti.
What?
ETCO2 intraoperatively was in between 54 to 56.
Alright, and any ABG monitoring, was there anything significant that was noted?
Chandni madam, are you logged in at two places? Because the voice is resonating. Actually, madam has asked about
I'm not
ETCO2 and
logged in at
ABG.
2 cables, just Zoom and YouTube.
Chandni, your voice is echoing.
Yeah, so just stop the YouTube. Stop the YouTube, Chandni madam.
Oh. Alright, stop.
Yeah, it's better.
So the intraoperative ETCO2
They had
never
asked
went.
a question regarding ABG.
Yeah, they got the question regarding ABG and ETCO2. Yes, yeah, Vikas sir.
So the intraoperative ETCO2 never went more than 40 was what Dr. Ratnakar told me. And that is why that was not my first, malignant hyperthermia was not my first diagnosis when I was called in to see this patient of high temperature. And about the ABG, Dr. Dipti has already mentioned that in her slides.
Yeah, can we go on?
Thank you, sir. May I continue? The next question is for Abdul, sir. The question was that it was difficult to make the diagnosis at suspicion of malignant hyperthermia. Also, should we give it by that time? Should we give Dantrolene if we are not able to make a confirmed clinical diagnosis and just
I'm sorry, I couldn't understand what she wanted to say.
He is saying that even if the diagnosis is not confirmed, can we give Dantrolene?
See, 2, 3 things are there. If they are going towards that direction, I think we should. One is high fever. Second is potassium going very high, and probably CPK going very high. We should be going ahead and giving Dantrolene, because earlier we give, better will be the results.
Yes, and here I think the raw score helps us. You
Yeah.
know, those various parameters. When we think that it is more likely to be MH, definitely go ahead with Dantrolene. Whatever that score doctor has already discussed in his presentation.
Yeah. Dr. Chandni, are we done with the questions?
None, 4 more.
Yeah, maybe after the first.
Hmm.
Chandni, please switch off your YouTube or just log in from one place only. Yeah, please go ahead, Dr. Chandni.
She's muted. Please unmute
I think
yourself.
we will go, Dr. Shilpa, you go on with your
Yeah, we'll go on to the
presentation,
first
then
case.
we'll
Yeah,
take the
yeah,
chat
yeah.
box.
Ganesh, Mr. Ganesh and Mrs. Varsha,
Yes,
can you
ma'am.
put
Yes,
on
ma'am.
the case? Yeah, first case.
Yes. Just a minute. Ma'am.
Yeah. Mr. Ganesh, make it full screen.
Yes. It's visible, ma'am.
Yeah, make it full screen and to the first slide. Next slide.
It's visible.
Yes, गणेश विजिबल आहे पण पुढच्या स्लाइड वर जा आणि फुल स्क्रीन कर.
पुढच्या स्लाइड वरच आहे मॅम. आणि
नाही पण आमच्या इकडे मूव नाही होते गणेश.
ओके मॅम, ओके 2 मिनिट.
बर, तोपर्यंत till then I will just read the question which I have with me. These are the questions which are taken from the internet. We had a 8-year-old 26 kg child for bilateral tonsillectomy with adenoidectomy. ASA grade 1 child, no previous anesthetic exposure. Patient was induced using JR circuit, pre-medication with glycopyrrolate, midazolam, ketamine, induction with oxygen, nitrous oxide, sevoflurane, propofol, and succinylcholine was given. Succinylcholine twitches were over and laryngoscopy tried. It was difficult to maneuver the blade, and the anesthesiologist noted masseter spasm. So the sevoflurane was switched off and call for help was done. So I hope the audience also have got the question, where a 8-year-old child, a normal child with no pre-exposure to any anesthesia, had come for bilateral tonsillectomy with adenoidectomy, and midazolam ketamine was given, sevoflurane, succinylcholine was used. Yes, so now with laryngoscopy, they found that masseter spasm was there. Maybe
Hello,
the
ma'am.
yeah, maybe
It's
the
visible.
anesthesiologist, yeah, it's visible. Ganesh, thank you. The anesthesiologist thought that first he should put off the sevoflurane. Kelkar madam, I wanted to know if I'll end up in such situation, is it possible that whether I should directly think of malignant hyperthermia, or even after scoline twitches, there could be some masseter spasm? And what should be my action? Suppose I'm thinking now, I'm very much, aware that there could be some entity which can be there like malignant hyperthermia. So whether should I deepen the plane, or with that masseter spasm, I would be able to mass ventilate at least the patient. I'm a private practitioner. I'm doing
When see, in my practice, I have seen one case. I distinctly remember one case of tonsillectomy where the patient failed to relax. There was a masseter spasm. Nothing else developed. That time we postponed the case. Actually, that was a case which happened in my own nursing home, and one of my students had come to anesthetize, and later on he had asked me what to do. And that day we abandoned the procedure. We brought the patient out, and next time when we did the case, we did it without succinylcholine, and it went ahead well. But when this scenario is there, definitely this goes to suggest that there is a possibility of MH being there.
Yeah.
So if surgery hasn't started, I mean, now at least after my experience with that MH case, which was so shocking, that I would suggest my surgeon that today we will not go ahead. Let us come out, and next time let us use a trigger-free anesthesia and see, and let us monitor this baby. So we will definitely have to monitor the baby later on. But otherwise, this definitely does indicate that it could be a case which is going ahead to develop MH. And sometimes I have seen these cases, you see that there is a picture like this and it doesn't have a full-blown picture. So it is very difficult to say whether it is a minor case of that MH syndrome, or whether it is just because masseter spasm is a known entity after succinylcholine. But to be honest, I would like to err on safer side.
Yeah.
And then we can even get the genetic testing done and we can go ahead later.
So I
Because
myself haven't.
this is a totally planned procedure.
Okay. Nandini madam, like now there is a masseter spasm. I have given scoline. The spasm isn't settling. So should I deepen the plane of anesthesia? Like the scoline action is done. Still I have a masseter spasm. Will I be able to ventilate with my GR circuit? Or should I deepen the plane of anesthesia or attempt a second attempt of intubation? Whether what I want to ask is whether with this masseter spasm, which could be query succinylcholine plus query MH, whether I'll be able to ventilate the child.
So frankly, I have no idea, because see, one thing is, I feel in today's day and age, whether we should be using succinylcholine, and I'm not saying just because I work in an institute, I'm just saying very frankly, because we have got other agents available. I've not used scoline for so many years, unless of course it is to treat laryngospasm, or if I feel that there is a maybe full stomach also. Nowadays we use atracurium or rocuronium, for RSI also. So first of all, I feel we should be cautious in using succinylcholine because you should be able to justify why you used in the event of any problem.
Like I'm a private practitioner, I have a bilateral tonsillectomy, the tonsils could be enlarged, and I have probably the nose which is blocked with adenoids. So I want something like RSI, a quick induction, quick intubation.
After you have given your propofol and sevoflurane, the patient is going to be relaxed. And at that time, you're going to check mask ventilation. If you can ventilate, you are justified in giving an intermediate acting relaxant. That's how I would think of it.
Okay.
Now, to answer your second question, so I have no answer whether, I wouldn't use choline in this situation, of course. Second thing is, suppose it occurred now, you've already given anesthesia. I wonder whether deepening anesthesia will relax the spasm. I don't think so. Kelkar madam may be a better person to answer this. I feel it will just go with time probably after some, in the older days when we would give choline, that time I remember sometimes the jaw would be tight and after some time it would relax and you would be able to put in the tube is what my limited experience is.
Yes, that's true. And there is no difficulty in ventilating, even though there is a masseter spasm. We can ventilate the patient.
Yeah, Avdut sir, I wanted to know, in your case, you had said that you gave rice tube lavage, cold lavage to the baby. So your baby was 12 kg. So like what number approximately the rice tube, and whether we should also give bladder cold lavage if you're suspecting malignant hypertension?
We had not given bladder, but we had given a rice tube lavage and we had given a rectal enema with ice cold saline. These two things we had done. Bladder lavage we had not done.
So it is much practical for a private practicing anesthesiologist. If help is there, we should think of if there is hyperthermia, then first symptomatic treatment thinking of MH, we should give rice tube cold saline lavage as well as rectal lavage, right?
Yeah, because urine, I thought, we should be knowing what is happening to the urine all the while because it was not coming.
Okay. Yeah.
So, and I never thought about it, to be very honest.
Yeah.
No,
So
but we have to
regarding the first thing, madam, regarding the first thing, the masseter spasm, whatever literature I was reading, everybody has recommended the moment you have masseter spasm, you should stop and do not deepen the plane. Do not try to do the surgery also. Let the patient come around, let the patient settle down, and you go for a trigger-free anesthesia later on. Don't attempt to deepen the plane by giving more agent.
Yeah, so that is the take-home message for the general private practitioner, that if at all there is slightest possibility that after giving succinylcholine or sevoflurane, you find some rigidity somewhere, just hold on, just postpone the case and plan it at a different date. Dr. Ankit sir, can you just again repeat? You said the circuit should be free of the volatile agent. So 10 liters flow for 10 minutes, you said, or for more time? Can you just repeat for us?
So it depends on your workstation. There are instructions in your workstation with your manual. They have instructions. So
Suppose
recommended is
I'm
10
using
to
boils.
90. So if you're using, so you should do it for at least half an hour to 1 hour is what they say to be have a completely vapor-free circuit. If you have charcoal filters, then of course it is not available, but the recommendation is only 90 seconds then with 10 liters.
No, suppose I'm using Boyle's machine with JR circuit.
So at least 20 to 30 minutes you have to flush the circuit. And it should be the first case of the day because most studies have shown that overnight some amount of degradation does occur. So it should always be the first case of the day. And all vaporizers should be it should be dismounted from the workstation. There should be no vaporizer lying on the workstation.
Okay. So if I'm a private practicing anesthesiologist, I have a case of myopathy for some surgery, then first I should always flush the circuit with 10 liters, for 30 minutes. And what about soda lime? Should I change it?
Ideally is to use everything new. Change soda lime. I gave 4 options, right? So you have multiple options. Like if you are in a private setup, the first option that I discussed was flushing the circuit. The second option is use of charcoal filters. If you have charcoal filters, then you need to flush only for 90 seconds. Other thing you can do is get your ICU ventilator inside if it is available. They are always vapor free, so that is always a safe option. And the fourth option I think was to have a workstation which is without any. Certain hospitals have a separate workstation, malignant hyperthermia workstation available where no vaporizers have ever been mounted on them. So those are the 4 options that you have.
Yeah, thank you so much.
Something, Shilpa.
Yeah,
Practically, see what happens is we don't have charcoal filters. We don't have spare anesthesia workstations even in our hospital. So we just kind of leave them, of course we change the soda lime. So first case of the day, but the soda lime is 100%. That is one thing you can ensure, new soda lime. It doesn't cost that much. So, and then you turn the oxygen on and we leave it like that. So it's actually not any scientific number, to be very frank. We just leave it on for about half an hour, 1 hour like that. And then we hope that, it's all free of residue.
Yeah.
And there is one more thing that we can do actually. We can do away with the soda lime canister and closed circuit. We can use a bench circuit, which is a new one.
Okay.
And so one more, can I just add one more thing?
Please.
In these kind of cases where you are suspecting malignant hypothermia, a low flow anesthesia is an absolute no-no. You should keep the flows high. You should not use low flows in these kind of cases. Keep the flows high.
Avdut sir, so what would you suggest our private practitioner, whether he should have a malignant hyperthermia trolley, like a difficult airway trolley? And do you have at your hospital, like have we have at anesthesiologists are making trolleys at their hospitals? Yeah, like since
I still don't have it even after losing a patient. I think it is not practical with our kind of workload in nursing homes, with the kind of staff we have. It's very difficult. Procuring dantrolene itself would be a task. And rest of the things, I really don't think would make a difference, because it's practically, I think it will be very difficult. Even though I know ideal situation, yes, but with the kind of workload and kind of staff, I feel it is not possible.
So at least with ice cubes, I think all the hospital filters, I mean, freeze might be having, but we can at least keep some cold saline every day in the fridge.
Yes, that's true. Yeah.
So cold saline can be added in the fridge. And what all the panelists, I want you to give us a take-home message that along with procuring dantrolene, can the patient be saved with, if it is not severe, with temperature control, control of acidosis, control of hyperkalemia. Also, secondly, I wanted to know whether every third day we should make a glucose insulin drip ready and keep it if we are doing pediatric patients.
No.
To run if there is hyperkalemia.
No. I
That
don't
is
think it
much.
is a wise idea. That
No.
is, I don't think it is a wise idea. Somebody may just run it just like that.
Oh,
But what I feel is that we should have a very high level of suspicion. So, and start treatment as early as possible. So if you have a higher level of suspicion, probably you will pick up things much faster and start moving much faster.
No, actually what happens is, if I'm a private practitioner, I see ETCO2 rising, I will try to hand ventilate, I will change ventilator settings. Then if I open the drapes, then I will see that the patient might be sweating under general anesthesia, and then start thinking. Some time is lost in that. So for this patient, Dr. Ankit sir, could you just summarize for us, after this patient who is induced with sevoflurane and succinylcholine, and masseter spasm is not settling, he is further going into rigidity, and the temperature is rising, and I'm not able to intubate this patient. So what should be my next line of treatment?
This will be like a difficult airway kind of scenario. We'll have to go in the CVCI kind of pathway. But as far as managing the masseter spasm and all, in this case, I think I'll stop everything and I'll try to make the patient awake and try to oxygenate him in some way so that he wakes up. And if in case if some malignant hypothermia is happening, then I will start cooling him down. I'll start managing the hyperkalemia. If it is happening, I'll start sending some labs or something.
Yeah,
so
but I think
management will go in that direction.
So prophylactically, Nandini madam, for us, sending an ABG is right from searching where the heparin is, where we have a syringe, where we have a ice cube, present in the fridge, that ice pack where we can send an ABG, and then calling the laboratory. So all that will at least take half an hour to 1 hour. Plus electrolytes, I think it will take 1.5 hours to come. So is it advised to give, if you're suspecting the temperature is rising, the ETCO2 is rising, can we give soda bicarbonate? And how much will be the dose for a child? And can we start glucose insulin?
So I think supportive measures you can start immediately, even without waiting for sending an ABG. We know that hyperthermia is occurring, hypercarbia is there. So once the clinical suspicion has come in your mind, you will immediately start. You should immediately start cooling. That is one thing. And if you can hyperventilate, then that will take care of the respiratory acidosis at least. Another thing you should do is at that point of time probably run fluids and catheterize also. So you can immediately pick up any myoglobinuria and see that, because in a lot of cases it is a kidney shutdown. Even in the Zen hospital case also the problem was that the kidney shut down. So once you keep the kidneys flushed, so at least you try to prevent some things which we can probably get away with this. Then of course once you are you can buy time, then do the you're expecting that there will be, that there is respiratory acidosis, you're expecting metabolic acidosis. Now the problem is if you give soda bicarb, you can exacerbate the respiratory acidosis if you're not ventilating the patient. So probably at that point of time, it will be a good idea if the CO2s are going very high, it is better to secure the airway, because at least you can control ventilation. So once you're controlling ventilation, hyperventilating, that is a time when probably I would still say I would do an ABG and then give soda bicarb.
Okay.
But if you are having an inordinate delay and you're saying hypotension is also developing, then maybe you think it is a metabolic acidosis. That's why hypotension is happening. Maybe you can give 1 ml per kg of soda bicarb. But then again, you have to hyperventilate them. I would say get
So
the
the
ABG
take
as
home
quickly
will be we can give soda bicarb if at all along with hypercarbia we are suspecting hypotension, and ABG is going to take time, so we can give 1 ml per kg if you have intubated the patient and there is hypotension occurring. Kelkar madam, I wanted to ask in some of the literature.
Can I?
Yeah, please.
Can I intervene for a moment? I
Yes,
would
yes,
just
Rao sir.
say that Dr. Nandini madam said, I think we should go down on succinylcholine now. I have not been using it for many years. And secondly, like what we do is after say 2, 3 patients, we normally don't do in nursing home setups and small setups. So similarly, in such cases where it is expected with syndromic kids and all, I mean, is it okay? I mean, to do these cases in setups, higher setups or corporate hospitals rather than doing them at nursing home level.
Yes, by all means. Yes.
Yes. So similar thing I just mentioned, Rao sir, like I go to most of the corporate hospitals also, but even places like Nanavati, etc., they don't have daltrozine. So if you have a case whom you are suspecting, or you are expecting something like a malignant hyperthermia reaction happening in those patients, nowadays what I do is I explain to the patient, I send them to SRCC because it is available at that place. Now, previously it was not available, so we were okay to give it trigger-free anesthesia because it was not available anyways at any of those places. But since it is available at SRCC now, I think we should give that option to the patient.
Yeah, that is what I precisely wanted to say. Yeah.
And Shilpa, one more thing is when you were talking about hyperkalemia, you can definitely monitor the ECG to see the changes if you can pick up on the ECG about hyperkalemia.
So we can see the loss of P wave. We can see the
and the
this
tall
wave.
T waves.
Tall T
If
waves.
you see any paired ventricular, I mean bigemini kind of thing, ectopics, then definitely you should go ahead with the treatment of hyperkalemia, even though you don't have the report.
Yeah. Now Rao sir added that he's avoiding scoline, but as we have seen with inhalation agents such as isoflurane also, it could be possible.
Yes.
Like suppose I have in a private practitioner, there is a CTEV or there is a palsy where there is just tendon release they have to do. And before giving caudal, I'll give propofol, I'll give pre-medication propofol, put an LMA and start sevoflurane and then give caudal on spontaneous. So I am avoiding scoline, but my sevoflurane or isoflurane may be still going to the patient. So any take on that?
You can use Siva for that.
No,
yeah, of course.
Madam, we do such cases day in, day out. Not all cases are susceptible to malignant hyperthermia, especially CP and all. They are not at all susceptible. They can safely use inhalational agents in these kinds of cases. So those cases where you are suspecting a muscular dystrophy kind of thing, or especially congenital muscular dystrophies where the muscle weakness has started at birth. those kinds of cases are very susceptible to these kinds of reactions. So you should know which cases you have to avoid inhalational agents. As a blanket, you can't avoid inhalational agents for these kinds of. Sevoflurane is a go-to drug for most of our pediatric cases, and it can be safely used in most patients. So the take-home message should not be that we should shift to TIVA, I think.
I agree with Ankit absolutely. And also what I do is I can't remember what syndromes are associated with MH, So when I know what it is, I go and, read and just check, whether there is any association. If there is, only then we need to avoid. Otherwise, even for taking IV lines, we are using sevoflurane all the time. And most of our patients don't come in with IV lines.
Yeah.
Okay, so we have Ganesh. Can I have the fourth slide? शेवटची slide लावशील का Ganesh sir?
Yes.
The next one, last. Yeah, so I was going through literature, and various syndromes and myopathies are associated with MH in some form. I may be completely wrong in some cases, but this is maximum I took, which is not repeated, and I took all this. So whether we should have this list with us, which we have to confirm that the patient does not have any of this. Nandini madam, what you have to say?
So I don't think, for example, in this list, Duchenne's, Ankit, if I'm correct, it's not really associated with.
It is associated with a similar syndrome, which is a acute onset hyperkalemia, which mimics malignant hyperthermia, but it is technically not malignant hyperthermia.
So as a dictum, Shilpa, what I do, if I have a kid with a myopathy, I try to go trigger free because I'm not very sure.
Yeah.
And even with this RYR and all, there are several other things, not only RYR. So it may be not tested also. And so any myopathy, typically we like to go trigger free. Having said that, sometimes if the venous access is difficult, we are still holding sevoflurane with a mask, but at the same time we are monitoring, CO2s and this thing. So briefly we may use, and then we go trigger free. So yes, some kind of, I don't know, maybe a common sense approach. If there is some kind of myopathy, I would probably err on the side of caution.
Okay, so myopathies we need to avoid, but maybe for IV line or this, we might cautiously use it.
And even for IV line, actually, you can use intramuscular ketamine, you can use Emla cream.
Yeah.
Midazolam spray are we using?
Yeah, that also is a good option.
But
yes, midazolam also.
Yeah.
But this list also mentions cerebral palsy. I have been using this.
Not associated with.
Not associated, exactly. Because I have been using a lot of things with CP periods.
CP is definitely not associated with MH.
Not associated with MH.
No.
Okay. Thanks. Yeah. Can we go to the third slide, Ganesh?
Shilpa.
Questions? Sorry. Chandni madam, can we take the questions in the chat box?
Chandni madam has forwarded the questions to me because of her audio problem.
Okay. Tejveer sir, can you take it?
Yeah. The question is to Nandini madam actually. Like if I have a case of MH and I give dantrolene, but it happens to be an incomplete dose because of inadequate availability, will it still benefit the patient?
I have no answer to that, honestly. I really have no answer to that.
And second question, similar related, was how does the time when dantrolene is given affect the prognosis of MH?
Yeah. So to answer all that question, whatever the literature is saying, because I don't have a personal experience of actually giving the dantrolene, although I have it, it is time sensitive. So the earlier you diagnose, earlier you suspect, first of all, you stop all the triggering agents. That is step one. So your dose of the triggering agent, you are controlling or you're limiting. Second thing is you give the dantrolene as early as possible. And they mentioned the dosages. Again, there is no upper limit which they have mentioned. So you give what you have and you hope that you are limiting the damage is what I would think.
There is an upper limit, 10 milligram per kg.
So that is reported in some literature, but if the hyperthermia is persisting, then you can keep on giving. So there is no upper limit.
There is a danger to liver. Of course, now you have to err on the safer side and you have to choose a better avail, lesser avail.
And Nandini ma'am, you mentioned about MH drill.
Yeah.
Could you just talk about it a little bit? What is it?
Basically, see, like for example, how we have the code blue drills, we have a code omega in a hospital for a massive blood transfusion kind of situation. So like that, what the JCI has recommended to us, when during our inspection is we run a image drill, which means that we have a mock patient and we have a kind of a mock situation where we are calling out that, okay, this is an image crisis. What do we do? So everyone needs to be, on the same page. So as the anesthetist, we will be doing certain measures, like say stopping the triggering agent. Then the thing about having cold saline always available. So cooling agents. Then having, of course, since we have access to dantrolene, we'll have to call for the dantrolene. So what is the process of, getting the dantrolene up? It's not too far for us. It's just in the basement. But still, I will have to obtain permission from the facility director because it is a drug which is quite expensive. Then they will be telling the parents, because again, somebody will have to pay for the drug. So that also would be there, informing the relatives. Then it will be actually making the dantrolene, because I believe it is quite difficult because 60 ml you're putting into. So one person is going to be occupied, or not two people who are there, your staff will be just occupied in making that dantrolene. So that is the entire drill, So what is the staff their responsibility? What will the housekeeping will do? He will go and get the dantrolene, probably get the cold saline, things like that. So how we have for code blue, what each person is supposed to do. This is what, is a recommendation from the JCI. So I believe that when we are going for accreditation, we are getting international patients who are aware, who are asking us questions. We need to be, up to date. And I'll take this opportunity to also tell, Shilpa was talking about in private practice and in this thing. I feel it should not, that line should be blurred now, because information technology is there. It should be there everywhere. So we should all be doing whatever is standard practice. I understand there may be some delay. For example, ABG is not available here, you sent it outside. That is understandable. But at the same time, certain things which are standard should be followed by everyone practicing anesthesia.
Ma'am, one last question. Somebody asked, is it not easier to use an ambu bag instead of flushing the whole machine for half an hour?
But ambu
Anyway,
bag,
anyway, you are not going to use any agents on that. You are
but
going to be trigger free. So you
how
are
will
just using it for ventilation.
ambu, how will you hand ventilate for the entire case?
So that's a question from probably from a private practitioner.
So there are a number of
Yes,
jugaads
that's what
that we have used
Keshav Madam
actually.
said. The vein circuit can be used. I have
Yeah,
one question for Dr. Ankit. Ankit, you had mentioned some statistics, the number of cases from 2000 some, and then suddenly we had a couple of cases within a span of 2-3 months. Can you just repeat the numbers?
so literature says it is 8 cases, like reported cases are 8 cases from 2001 in India.
That is what, 8 cases in almost 22 years.
Yeah, so
And
most of them are not reported though. They have not published.
Absolutely. So,
But I'm sure it's
what
a
is
gross
the general?
underreporting.
Yeah.
Ankit, I
Madam,
have
can you
it's
give
reported, but it is not
approximate
added in that.
percentage?
Sorry.
Yeah. What is the percentage of overall malignant hypothermia cases which can be expected? 18-20 years is too less a number.
Correct.
Yeah.
And Dr. Manjusha Savli, if she's there, she said both her patients were adults. Manjusha, madam, can you please unmute yourself and just tell us about your two patients who were adults? See, all the scenario we've seen are all in pediatric cases. In your adult patients, how did they present and what did you do, madam?
Yes, I'll tell you. The first case is not mine, my friend's case. It was in Saifi Hospital, spine scoliosis surgery. I had not seen that, but the patient was an Arab patient. And that was an adolescent patient, not exactly adult. But couple of months back in 2023 only, we had one case in Kokilaben Hospital. I can tell you about that because I was managing that patient. It was an adult 61-year-old patient. He was a UK national. And plus he is a chronic smoker. And we induced him on propofol, cisatracurium. We never use atracurium also and scoline also. Intraoperatively, we were managing with sevoflurane. The first 2 hours were uneventful. And after that, after 2 hours of the surgery, suddenly ETCO2 started rising. So first we thought patient may be chronic smoker, so maybe bronchospasm or something else. But surgery was a spine surgery, so patient was on the prone position. So we could not auscultate it, but still we tried to rule out everything. Nothing happened. We gave bronchodilators, everything, nothing happened. Then we changed the circuit, we changed the machine also. thinking in terms that it can be a malignant hypothermia. Unfortunately, we were not put temperature probe to that patient, so we were not knowing about the temperature. The blood urine was a blood stain, but cannot call cola urine because his catheterization was a traumatic. So he was having blood stain urine since that time only. So that was still intraoperatively when this happened, the ABG was showing hyperkalemia and ETCO2 was rising. So we told surgeon that we need to do something, you finish the surgery fast. Meanwhile, we change our circuit, we changed the machine also, anesthesia machine. Then we put the rectal probe, temperature probe, because patient was in a prone position. So in rectal position, temperature probe was showing temperature of 37.5. That was not much high also. So nothing happened. So we consulted the pulmonologist also. So first differential diagnosis they made, it was some respiratory complication, which we were unable to explain. So ultimately we finished the surgery, we made the patient supine, and we still suspected it was a malignant hypothermia because that time the temperature was 38.5 degrees centigrade. So ultimately we shifted the patient, we started cooling action, everything. We never had a dantrolene in hospital that time. Now it is available. Then we shifted to the patient to ICU and their patient arrested. We could survive him. He had resuscitated. We could survive him. We had an arterial line since beginning. There we put the central line also. He was put on continuous dialysis. And after 6 days, we could extubate him. But again, after 7 days, after 24 hours, he was intubated for the multiple infection. Then he developed the hospital-acquired infection, that is Elizabeth Kingi. And after the surgery, almost after 30 days, he expired. Then there was intensivist was still not ready to believe it was malignant hypothermia. But we insisted that we need to undergo the investigation because patient was not an Indian national. So we sent the sample for a genetic study to MedGenome only. The report almost come after 28 days, but it was showing RY1 mutation with autosomal dominant prone for malignant hypothermia. But we lost the patient after 30 days.
Oh, but at least you could prove that it was malignant hypothermia.
Yes, that is why we insisted in
And that
must
have saved you also because medico legally you could have got into a problem.
Yes,
Being
yes.
UK international person. Oh, okay.
And once the patient goes to the intensivist, they start managing on their terms. But this time we insisted, no, we have to do genetic study.
Madam, did you say that dantrolene is available at Kokilaben now?
Yes, it is.
It is available at Kokilaben also now.
Yes, yes. Recently they got it after these incidents only.
Okay, from where can we know?
No, I don't have any idea, but I'll find out.
So that's one more option that we have now. I think Kokilaben is much closer than SRCC.
Yes, it's there, but I don't know the policies here. We need to discuss with the management on what basis they got, what are their policies to give it to other patient. I don't know. How many ampoules we have got, I
And
don't have.
whether it can be given to outside hospitals.
Yeah, madam.
And how many ampoules are available? I don't know that. We need to find out.
Madam, please find out and let us know because
Yes,
Kokilaben is closer to us than.
Here I think what I suggested will work. That the representatives of the association should go and meet Kokilaben people.
Exactly.
Yeah. Explaining them how important it is to save their
And this
patients.
is very important to us because we get many international patients.
Yes.
And these patients are more prone for these genes mutations.
Oh, is it? It's that way?
Yes. UK nationals are more prone for malignant hyperthermias. They have those gene mutations, RYR1.
Okay. But he did not undergo anesthesia ever before till the age of 6 years?
No. This was the first time he was undergoing the surgery.
Madam, Nandini madam.
Yes.
Can I ask you a question?
Yeah.
Madam,
On the way. It's on the way.
When you feel patient could be a malignant hypothermia, maybe. So in those cases, you do, the inhalational and succinylcholine free anesthesia. You give. Wouldn't that, so that patient would be safe. I mean, at that time, the anesthesia would be uneventful. But wouldn't that miss out on a diagnosis, if, and later on patient presents, I mean, I'm just thinking aloud, is
You
that...
Can I answer that?
Yeah, madam, please.
Yeah, you can always advise them to get the genetic testing done later on.
Later, okay.
Yeah, because it is not very expensive, you see.
Okay.
So even for the family, it is of interest. Even for the patient, it is of use to know for sure whether the RYR1 is normal or not.
So in those patients, madam, Nandini madam, do you advise them to
We do, but the thing is, see, when the patient is coming for surgery, that time we can, if we advise, it will take 3 weeks to a month, So then we cannot just, the surgeon won't be very happy. So if there
No,
is,
they can do it later on.
we can do it.
Yeah,
So we
yeah, they can.
advise. Again, everybody will not go and do it, madam. That is a problem. We can only advise.
Yeah, that is
That's
possible.
the economic constraint, and we just tell the surgeon.
But
And
then we have done it and we have documented, legally speaking.
Yes.
We have to document and we have to explain that it is a possibility and it is better in the interest of the patient to get the testing done. Now, whether to get it done or not, it is the patient's prerogative. But as far as courts are concerned and our ethics are concerned, we have done the job.
Absolutely.
We are
please continue.
concluding at the panel. The next, I'm so sorry.
I said you were to
Yeah. See, the next two cases as
Shilpa madam, can I make a quick point regarding genetic studies? So as far as genetic studies are concerned, there are more than 80 genes that have been reported to be associated with malignant hyperthermia. So just proving that RYR1 is affected, it doesn't rule out malignant hyperthermia. There are more than 80 genes that are available. So even if a patient is say negative for RYR1 genetic testing, he can still develop an episode of malignant hyperthermia because there are other genes that are involved.
When you send the sample, the whole genome sequencing is done.
Yeah, so they do more than 80. That is what I was coming to. They do a sequence of 80 genetic studies. Like it's whatever is available to us, it's a test for 80 studies.
And is sodium channels also involved in malignant hyperthermia?
No.
Mainly calcium.
No.
Okay. Only last two questions for the panel. So whether dexmedetomidine and lignocaine, as you mentioned in your presentation, Dr. Ankit. Whether dexmedetomidine can be useful, helpful for tachycardia, or it should be avoided, it can aggravate the arrhythmias?
You mean after an episode has developed?
After an episode. Kelkar madam, what do you say?
Yeah, clonidine is shown to be useful in these cases. So dexmed also will be useful. Yes, because in neuroleptic malignant syndrome, which is similar to MH, they have advocated use even of clonidine.
Okay. And Nandini madam, I wanted to know there's something called as forced diuresis. So whether
Borivali.
Yeah, that should be started.
Borivali is Jaul.
Yeah. So basically, you ensure that the kidneys don't shut down. So catheterize the patient, furosemide is recommended, and lot of fluids, so that the rhabdomyolysis, which even if it will occur and block the tubules, that you're trying to basically prevent.
So Lasix can be given, and fluids. What rate fluid should be going?
I think we'll have to see the weight of the patient and then just run it. I mean, it's empirical. Basically, you are ensuring a urine output in a child. I would at least 2 ml per kg. In an adult, maybe it's little less, but 1 to 2 ml per kg, I think we should have urine output. In the case
Here we can take the help of the USG. You see, you can see the IVC compressibility and you can judge the volume status. If the patient is dehydrated, you can give fluids, and of course, you have to look at the urine output. Yes.
And dialysis can.
You will always involve a nephrologist in such cases, and they will advise these things. I think it's a specialist job, and they should be the ones doing it. One more quick point over here is the dantrolene that comes, especially the 20 milligrams, which is procured at SRCC. I think you have the 20 milligram one, right?
Yes,
madam.
Yes.
So that has mannitol in it. So mannitol previously was a part of malignant hyperthermia cart. But nowadays, since it contains mannitol, it is no longer a part of malignant hyperthermia cart, and it is just Lasix that should be available because mannitol is anyways going with the dantrolene.
And what about allergy of dantrolene? Is it reported in literature? I did not find any.
No idea.
No. Okay, Avdut sir, for private practitioners, any last point?
Only thing I would say is suspect it early.
Mm.
I mean, don't wait for a long time before you start the treatment, because earlier you treat, probably even if without dantrolene, you might just be able to get away. If you suspect it late, then probably it would be too late.
And early call for help.
Yeah.
So
And I would add that in a pre-operative evaluation, try to find such like we anticipated difficult airway, we anticipated malignant hyperthermia. You can think of and try to
yeah.
pick them
So
up in a better setup with a better backup.
so Rao
Doctor,
sir, want to conclude? Yeah. Sorry.
1 minute. Dr. Ankit, which patients you definitely refer to? I mean, you give that option of SRCC. Which syndromes or which myopathies patients? I mean, suppose we see in a PAC some patient, and which we should also, can you guide us on that?
So basically, madam, it's a family history. If there is a family history of unknown deaths in any of the close family members, so those kinds of patients you should be suspecting malignant hypothermia. And most of the muscular dystrophies where muscle weakness has already set in. So those kinds of cases are very prone to developing those hyperkalemia kinds of things. So those cases you should be very careful, and you have to make your judgment calls. Like you have to be always in the discussion with your surgeon and do what's best for the patient.
I agree with Dr. Ankit. In my so many years of practice, I have had one patient who was very scared of anesthesia. So he explicitly told me कि मेरे घर में 4-5 लोग मर गए anesthesia की वजह से operation के time पे. Okay, so that had, even I was a little I was very anxious. Luckily, I had to do that case in a regional block. So, but at the back of my mind, it was always there because he was specifically telling me, मेरे 4-5 लोग मेरे घर में रिलेशन में एक्सपायर हो गए ऑपरेशन के टाइम पे, कारण मालूम नहीं पड़ा, all those. So Ankit has come out with a good point that if we should start asking history of anesthesia or complications in relatives other than the patient himself, or close relatives.
So I think we sum up here. Nandini, madam, what would be your take-home message for us?
I think one important thing which is monitoring, So yeah, mandatory monitoring. Everybody is now, I'm assuming, doing ETCO2, but also temperature monitoring is a minimum mandatory monitoring, and it should be monitored for all cases. Put your skin temperature probe on and monitor it. So at least you catch it early. ETCO2, rising CO2, rising temperature. And second thing is, have the same standards of practice wherever you're practicing. We shouldn't have the differentiation between a nursing home or a corporate hospitals. As much as possible, try to practice, safe
Do
anesthesia.
you take the arterial line also for such patients?
Not really. It depends on the case. It really depends on the case. That case which I had was a major case, proven R/R mutation. I was going trigger free, but I took the line because you might want to do samples, and it is anyway. I would do it not only for the ABG but also hemoglobin and things like that. So it depends on case to case.
Correct.
Yes, sir, madam, what would be your advice for us?
The most important advice is, we always think whenever we come across an accident, we think it will not happen to me. Like that. So we should know that this is a rare thing, but it can happen to my patient. So it is always better to be forewarned is forearmed, you see. So you should be ready in your mind. If some such thing takes place, what are you going to do? What is going to be that image drill should be ready in your mind, so that you can motivate, you can collect the team, and you can start become the team leader, and you can get the things done.
Madam, when you say delayed malignant hypothermia, it can happen how many days post surgery?
It is within the immediate post-operative period. Then only it is said to be delayed malignant hypothermia, not after full recovery
So
from
you
anesthesia.
should have had signs, symptoms during surgery and
No,
immediately
not necessary. There are some cases which are presenting after surgery is over.
after surgery only.
But not more than 24 hours of anesthesia.
Okay.
Yeah, our honorary secretary, sir, Dr. Rajesh Tagadpalli, sir, is here. Sir, we wanted to know how are the practices in Nanded? Whether halothane is still used, or have you all shifted to sevoflurane? How is it? Or scoline is still used in private practice?
Whereas in Nanded, ma'am, there are so many small nursing homes, and we are not getting all the anesthesia equipments, not even the workstation also. Halothane we are now very rarely using. When I came to Nanded, that time we were using ether also. Now the sevoflurane is available, isoflurane is available.
Okay, and what about scoline? Still using it?
Choline still using.
Okay. Ankit, sir, what would be your take-home message?
Even in Mumbai peripheries, smaller nursing homes, I think a lot of people are still on those called basic. People are still using halothane in Goldman. So I don't know. And we staying in Mumbai, we are talking of malignant hyperthermia. I don't know how many cases must be happening in the peripheries or smaller rural places which are not reported. That they must have been taken as any anesthesia mishap or some intraoperative complication. But then that is a fact. So since Dr. Tagadpalli is here and talking about, I'm just delivering off the discussion a little bit, talking about the procurement of dantrolene. Kelkar madam has said, he as an association, even if he shell out some money and create a fund to, at the same time, I feel we as doctors and our association should approach the um, government or the local body. And 2.5 lakhs is not a lot of money for a government hospital. If Kokilaben hospital can afford, I'm sure HN must also be having it. But it has come out today. So, big hospital like AIM Hospital or Nair Hospital, if they intend to, keep it, that would be great. Secondly, if the government decides to give up the GST on such life-saving drugs, that also makes a lot of difference.
Yes.
So I think here the body should approach the right letters to the concerned health department and try to get these things done. I mean, that would be much more practical. And I think if we put up something, if some mishap happens, politicians come, they talk nonsense about the hospital. But we as a doctor's body, we don't approach them for some good thing for the people. It's time to start approaching them. We should get them involved. And I think it can happen if you handled it well. As a body, as an individual, I can't go. But as a body, ISA body, a local body, a state level, if you go and talk to the health department, for a lot of money is there with the municipal hospitals. A lot of grants are there. They can have easily 2.5 lakhs is nothing. So we should work on that level also. That is my.
Can I add? Dr. Ankit mentioned about the 250 milligrams vial. How much is that costing? How
So,
much?
madam, if you see in dollars, it is just $3,300, which is probably less than what Nandini madam has got it for. But the price is higher because of the gray market price. So, if the government does something about it and makes it available, then it is not that expensive. Even that Rhinodex, which I mentioned, 250 milligrams, is just $3,300. So, if you do a conversion around,
Government will
say,
never do
85, so
anything
it's just
unless
two
they
and a
know
half
about
lakhs.
it. That is what I'm saying. We should make the government also aware that this can happen.
Yeah. That's the most important thing. Government should be involved, and I think BSA also
That
can
is
find
what
some
I mean
CSR
when
and get some.
when I'm continuously saying that we have to do something at the level of association. That is exactly what I'm saying. That if the association approaches government or any authorities, it has a better impact, you see.
Yes.
So we have to.
Is Balaji sir is there?
Call this discussion. Rajesh and Balaji.
Yes,
So
yes,
Balaji
ma'am.
sir is
request
there.
that Maharashtra state chapter also does something about this.
Yeah,
Yes,
Dr.
we'll try,
Balaji.
ma'am.
Balaji sir is there.
Balaji sir had to leave for.
Yeah, he's left.
Okay, Anita madam is there. Welcome, Anita madam. Our president.
Hi, Shilpa.
Yeah.
Thank you.
Madam, you have to say something.
No, actually, as a society, I really want to do, we should do something about it, because anytime it is not acceptable that any patient is dying because of lack of a drug, and which is a totally, iatrogenic cause of death. So, but how can we work at the society? I want actually all your ideas, and I would welcome everybody's ideas.
Madam, first thing, that is what I said. We should write letter to the health department and get the GST and input is cancelled, and try to make them understand and make it available.
See, it has to be written. The head of the department is not the deciding authority. It has to be
Ganesh, please
written to
mute.
the government. The secretary,
madam,
the
I
DMAR
have a,
secretary.
madam,
Dr. Bala Venkat had joined. He's in Seoul, but I had requested him to please join for some time, because this, if at national level some decision is taken, then maybe, it would be helpful for the other associations also to follow. So I was hoping he would join for some time, but unfortunately he could not join. He's in Seoul just now. He said, I'll try if I can join, but I don't think he could join.
Madam,
So
if I may say something,
Today, so it must be difficult.
So Anita, and so as an association, I have a contact with the person. He's a father of a kid who's got epidermolysis bullosa. So he's fighting at the state and national level. Actually, he's working with the authorities, and he's got actually insurance cover for his own kid, but also working across for all kids with epidermolysis bullosa. So I have approached him, and I think we should, what I'll do is maybe introduce you to him, introduce ISA to him. So basically, he knows people in political circles, and so these are the people you can liaise with, and basically we have to work at the health ministry level, at the national level, at the state level, and it can be done. It can be done, but it can be done at the level of our ISA, not individual, not me or single person. So we'll
I
get
must,
down the cost. We'll get down the cost considerably.
Yes, congratulate ISA Borivali that because though it looks like there is no way that we can go ahead, but by discussion only the problem can be solved. And I am so happy today that we are discussing about this. And though the number of cases is very less, but we can really, there can be a way forward to this, as Nandini madam has said, that we can contact government officials, and they can make it available in a subsidized way. Something can be really
we should do something as an association. ISA should do something.
And
all of us together can put forward a letter or something to the health ministry, making them aware of this disease, and that this one vial can save a life. And if you can make it available at a lower cost,
Madam, actually, I had talked with Neon about this, and they can take out this molecule. And as they have done with Sugammadex, why the cost is high is because it is not used. That is why the cost is very high. So how they could reduce the cost of Sugammadex? Because now we have found new indications for Sugammadex, and it is being used. So they can reduce, and that way they can make available even dantrolene. So but it takes some time. They are
time. The research department will have to do something.
Yes.
And I'm really very happy. I want to have a note here, because this was a point of discussion in our general body meeting in Misakon. And ISA Borivali has really taken that point seriously, and they have put the
Yes, madam, we
this topic for
are
discussion.
really thinking, because we are 250 people, and if we even collect 1,000, so we can make this one vial available for at
one
least
set
people
can be made available, and that we can do at our level. We don't have to ask anybody at all.
Yeah. So 1,000 per head is not so much of an amount. And if we can make it available for our people, and of course the people close by, I think it would be some achievement. That's why that was the main idea of keeping this webinar, to discuss how dreadful and scary this disease, situation can be for a private practitioner, for any anesthetist. It can be a absolute nightmare. So that is why we thought, if we can bring out all the worst possible scenarios and make people aware how and how dantrolene can save a life. As people said, that it gives dramatic response. It is almost like using Sucamadex for the relaxants, and you see immediate effect. Immediate similar dantrolene is going to give immediate response, and I think it's something we should keep as a safety. Agreed, it has a 2.5 year shelf life, but I think it's worth it.
That is what, no, that's why I equated it to the insurance premium.
Exactly.
Doesn't
And
make
madam,
you
somebody in the
repeat
chat box wrote that don't we keep intralipids for local
Yeah.
anesthesia?
Yeah.
Don't
Right.
we keep intralipids? We hardly have to use it. We have rarely used it. But don't we keep it as a standby? Of course, the cost is much less. But this we are buying as an association.
Yes, yes, right, right.
And this
So,
Lipid also, for few years ago, it was not available.
not available.
To call that brown person that make it available here at least. And he used to say that, madam, at the stockist, it is there and it just gets expired. Nobody wants it. So he never used to make it
But now
available.
we-
I
now
literally
we
had
are
to
aware.
fight with him. So now it is available, and even intralipid 20% is freely available. Other companies.
Available, and everybody started keeping it
Everybody
in their
started.
rotis
Yeah.
because they have seen the response and how it can save a life.
Yes. So
So
that's what
I
I'm
think
saying. If we are, if the company people will realize that okay, there are takers for this, then they can actually reduce the price. The price is very high because there are no takers.
And basically, Anita, if we try through association at government level, even the price will come down. You see,
Yes.
if they know that regularly it is going to be bought,
Yes.
even though because our individual company, indigenous companies might take a longer time to develop the molecule and all, but till then we can definitely try these ways to procure the drug. You know, the drug
Yeah,
is available.
we have with us our Misa News editor, Dr. Parna Thakkar, madam. Madam, hi. You want to say something?
Yes. Now I've been hearing the discussion, very good discussion, and it's one topic which, all of us are not that much aware about it because it's not that common. Now, when we are discussing about procuring dantrolene, I personally feel that rather than taking all the responsibility ourselves, we should also actively involve surgeons and create awareness about it, because see, any patient is a joint responsibility, and if the surgeons are not aware about it and we at our level only keep doing everything, then whatever we are doing will also not be appreciated by the surgeons. And secondly, we want to share the responsibility with the surgeon for every patient. So that is why the awareness about this problem or this disease has to be known to the surgeons, and jointly we should take decision of buying the drug, and I think involve surgeon. That's what I would like to say. Thank you.
Our private practitioner forum, sir, Dr. Neeraj Jindal, sir, is there with us. Sir, you want to say something? Jindal, sir.
Madam, I had a question that most of the patients are budget patients.
Yes.
So even if you feel we need dantrolene, dantrolene gets available also. If the patient is not ready to pay, then where do you stand?
Good question. Good question, Dr. Jindal. So if we keep a stock and if the person doesn't pay, then what do we do? Madam, how do you all do? What do you all do,
We need to
Nandini madam?
take it written from the patient's relative that they don't want to pay. And that much consent we need to take from the patient relatives that they're not ready to pay in spite of this is available in our hospital.
So,
If the patient needs it, then what do? You can't let the patient die. I mean, if the patient needs it and patient's relatives say, okay, we don't want. I mean, so what to do?
It becomes like a do not resuscitate position.
Yes, yes, it becomes it is the patient's relative responsibility. Yes.
No, madam, further going on, if the patient says, ki, what are the chances? Like, do you guarantee the patient will survive or something like that? So we can go out of the way and, accumulate the money.
It is like any other disease. Like suppose there is a stroke, acute ischemic stroke. We come across this that when we tell them about thrombolysis, they say, "Can you guarantee?" How do we sort of counsel them? Similarly, nobody can guarantee, but there are higher chances of recovery that we can definitely say.
Dr.
See,
Tendulkar, sir, you want to say something? Dr. Ganesh Tendulkar, sir. Dr. Ganesh
No,
Tendulkar, sir.
no.
No.
Thank you so much.
Yeah, Dr. Sandeep Prabhu, sir.
Madam, as
Madam,
madam said,
Dr.
hello.
Vatkar from PCMC, SAPC. Hello, Dr. Vatkar
Yeah,
from
yes,
SAPC.
madam.
Yes.
Welcome.
Oh, yeah, welcome. Madam, very nice discussion I'm hearing. Like there are so much money lying in the India, in the political fraud and all those cases. Can we write to the health minister, Dr. Bharti Pawar?
We can
Can
show
we
the
raise the issue?
Yes.
Dr. Mansukh Manvia, or I can straightly write to Dr. Modi, Mr. Modi also, and raise the question, raise this matter in his Man Ki Baat. So that if that is the, because on my government, like he's got his Facebook page. So on that we can raise this question, like so many patients, number of patients are dying unknowingly for no reason, and it has been found that malignant hypothermia may be the cause, and the dantrolene is not available. So in such a rare conditions, if everything is available even from abroad, why not dantrolene? We can raise this question repeatedly, and then I think there must be some effect will be seen. I think so. I hope so.
Yeah, I think we can at least make the efforts. Then
Yeah,
whether
so
it will happen,
structured efforts should be made. Yeah, Dr. Sandeep
Consistent
Prabhu.
efforts ultimately pay. Slow and steady wins the race. I think so.
We can actually tag the mygov.com and tweet about this, but it will have consequences that may not lie in our hands. I mean, if you make everybody aware about this, and if something happens and people know, okay, this thing happened and it was not available. So it is a dual-edged sword if you put it in social media, and then everybody knows about it, and they also know that, okay, it was not treated at this and this place. But it is a good idea to tweet about it so that,
no, so maybe I think going
No.
just writing a mail to letter or a mail to the health ministry or something, maybe that would be.
Madam, they respond to tweets immediately.
Why not try? Why not give a try?
It is better not to mention on the social media. What Anita says is quite right. If we want to approach the government, we have to do it
We
properly.
should do it directly
Yes.
to the health minister.
Directly
Yes.
having an appointment, discussing with them, explaining to them. It should not be like what Anita says is very correct. That
Correct.
any people are unaware of all these details, and any death they will
We have to make a
attribute it
start.
to malignant hyperpyrexia. So that should not happen.
And
Yes.
anyway, there is no good, general public, there is opinion against doctors, so we have to.
So we should not increase the animosity.
Yes.
Yeah, you're right, madam. Right.
Yeah, thank you. Thank you.
I think excellent discussion, madam. Thank you all chairpersons and panelists. Super.
Madam, I think Dr. Sandeep wanted to, sorry to interrupt.
Yeah.
Yeah,
Sure.
Sandeep.
Sandeep?
Hello, can you hear me?
Yeah.
Somebody has said ki if dental is available and still because of budgetary constraint they are not ready to take it and we sign a consent. How do we stand medico-legally there? Hello, could you hear my question?
That is the whole question.
That is the answer.
We may think of people contributing and arranging and having a stock of dantrolene. There are three problems about it. One is we may not land up using it. So the shelf life, by the time you get it, it's already 3 to 4 months gone. So we have it for about 18 months to 20 months. In that period, if it is not used, it is wasted. And you have to go for another stock. Second is when we use it, we cannot expect returns from that. Because 75% of the people will not be able to pay for whatever reason, will not pay. But if it is available, then morally, legally, it will be binding on us to make it available. But as Madam said, if they will symbolize, we give the patient options. ये देने का है यूरोकाइनेस देने का स्टेप्टोकाइनेस, this is the cost of this, this is the cost of this. We take it in writing. As patient has been explained, patient has decided to go for this. Some people don't accept. They don't say हमको नहीं चाहिए. So we take it in writing. So that is the best way to go about it. Take it in writing that this has been offered. The patient doesn't want to take it. So medical legally, yes.
Our
I think
treasurer,
I'm right.
Dr. Sorry, our treasurer, Dr. Kalpesh Gaikonde, sir. Dr. Kalpesh.
Hello, madam. Thank you. It was indeed a very nice discussion today, and on a very important and interesting topic. So, at the outset, I would really like to thank our SAMS, that is Society of Anesthesiology of Maharashtra State office bearers, Dr. Rajesh Tagadapalli, Dr. Balaji Asegaonkar, Dr. Anita Nehete, Dr. Parna Thakkar, for attending, for the esteemed presence in today's webinar. And of course, our ISA Borivali committee members, our very own committee members, and Dr. Amula Parikh, Dr. Rajesh Rao, Dr. Rajiv Garud, Dr. Shilpa Tivaskar, and of course, special thanks to Dr. Tejveer Singh Chauhan, who has organized this webinar and brought all of us together. Thanks to our panelists and speakers today, Dr. Deepti Thakur, Dr. Avadut Kulkarni, Dr. Ankit Desai, Nandini Dave Madam, Kalpana Kelkar Madam, and of course, the chairpersons, Dr. Rajesh Rao, Rajiv Garud, and a moderator, Dr. Shilpa Tivaskar. And finally, last but not the least, all the delegates for patiently attending this webinar. It was around 3 hours webinar, and everybody patiently attended, put up very good inputs, especially on how to procure dantrolene. I hope we take this step forward. We don't stop at this discussion, just the discussion level. We implement it, and indeed we would achieve the best for our patients and for our association. So thank you very much, everyone. I would like to close this webinar.
I would
Thank you.
also like to thank the Jenica Technologies.
Yes.
Yeah,
for
of course,
providing this
Jenica
platform.
Technology, Mr.
Abhijit Kulkarni.
Yeah,
and,
Ganesh and Varsha.
Ganesh.
Yeah.
And one more
Thank you very
We
much.
have had a very good attendance right from the beginning, 100 plus. We could accommodate only that many numbers on this Zoom platform. I have not yet to get the numbers on the YouTube channel.
I would like to
which,
request
Dr.
our
Chandni
secretary to increase the strength of this, the capacity of the Zoom meeting.
Dr. Rajesh
We will be
Tagarpalli,
doing
sir.
Yes. I will try definitely.
He has assured me
I would like to congratulate ISA
And
Borivali
last
for
but
the
not least, I think
very
Dr.
good seminar.
Alpesh Bhanushali, who is always behind the curtain.
Yes, he made an
Dr.
excellent
Alpesh.
flyers, and Dr. Chandni, of course. Both of them were excellent in their management of the intricacies of the webinar.
Dr. Rajesh Tagarpalli would like to say something. Sir.
Congratulations to ISA Borivali, the whole team. You have taken a lot of efforts, and the webinar was very excellent. Thank you so much.
And thank you, sir, for providing the platform to us. But as somebody said, we need to increase the capacity.
Yes, I will try definitely.
Thank you, sir. Thank you very much, everybody. Thank you very much.
Thank you. Good evening.
Thank you.
Thank you, everybody.